Good afternoon and welcome to the third semi-annual Hackensack Meridian Health Pediatric Orthopedic Symposium hosted here at Jersey Shore University Medical Center and live streamed to our remote audience. Thank you all for joining. I'm Garner Smythe, the Director for the Orthopedic Care Transformation Service, and it's great to be back together for this symposium, and it's my pleasure to get us started and welcome everybody to the program. A few administrative items to get us started. So for those on joining remotely, these instructions are pasted in the chat and it's largely for you, but make sure when you sign in you use your full name. The course evaluations is really the critical piece to get credits, and so make sure you complete that course evaluation and you should receive your credits shortly thereafter. If you don't receive the QR code or the email, feel free to reach out to the Symposium Planning Committee. And then a couple of interactive capabilities during the symposium. There's a Q&A function for presenters to ask questions of the presenters, and then there's a live chat for any operational issues. So with that, just one quick thank you and lots of thank yous to go around, but particularly for the Planning Committee. So we're back here again, and we've done this a number of times over, but for me, every time I'm blown away by how the whole team comes together under Jen's leadership and pulls out all the stops, makes it all happen, and I think it comes together really nicely, and I think you'll agree with me tonight. So join me in a round of applause for the Planning Committee. So before I introduce our first moderator for the evening, I did want to call attention to something to be thinking about throughout the evening. And as a non-clinician, it appears to me that pediatric care, more than others, involves a lot of nuance. Every patient, every encounter, there's a longer list of variables, unknowns, uncertainties, and that requires heightened focus. And beyond that, a tremendous amount of teamwork and collaboration across different disciplines. And those two things, teamwork and collaboration, are largely based on trust and respect, rapport, and relationships. And those relationships take time to develop and maintain. And tonight's event is in part all about that, in that coming together here this evening to ensure that the collective connective tissue between clinicians and different disciplines is intact and strong at this institution and throughout our network. And so it's a wonderful thing to be a part of. I'm very appreciative of everybody prioritizing this and being here with us tonight. So our first moderator for the evening is Dr. Paul Haynes. And Dr. Haynes is the chair of the Pediatric Orthopedic Service here at Jersey Shore University Medical Center, amongst many other hats that he wears in his practice and here on the campus. But admittedly, for me, he is the genuine, caring, responsive professional that took care of my daughter when she broke her arm. So no kidding. Just last night, very coincidental, she's jumping on the bed, the standard stuff, stop doing that, you're gonna fall off, get hurt. And she says, when did I break my arm? I said, last summer sometime. And she said, no, when? I said, maybe this is a strategy to extend the bedtime routine. But I continued with it and said, well, school had just let out. It was the first Monday, so maybe June 19th. And she kept jumping and nonchalantly said, that was the worst day of my life. And kept smiling and jumping around because kids don't have any appreciation for the gravity of something like that. But it registered with me, and she wasn't far off. Her 7 years on this planet, that was a very low moment for her. And so what happened right after that, though, I'm very grateful for and very appreciative of. I reached out to Dr. Haynes because of office schedules and time. I wasn't able to see him, but within 24 hours, we had seen Dr. Lentz from the practice, who you'll hear from later tonight, and we were walking out of the office with a happy 6-year-old girl with a smile and a colorful cast. And it's tough to put that into words, that impact. So I know that's a day in the life of the clinicians in the room, but for me, I'm very appreciative of that. Beyond that personal connection with Dr. Haynes, working with him over the last few years has been a real privilege. You can see in his bio credentials and experience and accomplishments, but beyond all those things as well, he's a great leader, and a great collaborator, as evidenced by his continued sponsorship and leadership of this symposium now for the third iteration. So please join me in welcoming Dr. Paul Haynes.
Thank you very much. Well, I thank you for the kind words, sir, and I'm absolutely going to steal that connective tissue thing. That was great. So I just want to take a few moments. I just wanted to, again, also thank our Pediatric Orthopedic Symposium management organizational team in particular, Ms. Jen Palmer and her group for sure, the dedication and commitment and her remarkable organizational skills really were greatly appreciated. In addition, Ms. Kim Mills, Sarah Edenbaum, and of course, Mr. Smythe, we greatly appreciate your efforts and talents. I'd also like to thank some of the administration, so in particular, Dr. Paul. His leadership and efforts to improving the pediatric specialty outreach and education is much, much appreciated. And lastly, I just wanted to take just a brief moment and recognize the remarkable contributions of Dr. Samuel Thomas to the Pediatric Critical Care Department at Jersey Shore University Medical Center HMH community for the past 23 years. His infectious smile, compassion, professionalism, and his friendship is greatly missed. Just a few things about HMH itself. So we are ranked #1 in the state and top 10 in the Mid-Atlantic region in the U.S. News and World Report, which everybody hears about right about this time of year for 2024 and 25. Hackensack Meridian Children's Health comprises of 2 children's hospitals, namely Joseph M. Sanzari Children's Hospital at Hackensack University Medical Center, and of course K. Hovnanian Children's Hospital at Jersey Shore University Medical Center here in Neptune. We are also ranked in pediatric diabetes and endocrinology, pediatric and adolescent behavioral health, and pediatric urology. Outside of our children's hospitals, we do have also local, some of our local or sister hospitals, in particular JFK University Medical Center in Edison, and of course Old Bridge Medical Center, both of which have a whole host of specialty children's services. With the access here and our sister hospitals up north, we have access to 50 general pediatricians and more than 200 pediatric subspecialists in really 30 different areas all across the state. So it's no wonder that the CME today features not just pediatric orthopedics, but indeed, to agree with Mr. Smythe, this is a multidisciplinary approach, and we greatly appreciate our colleagues. And that was the whole idea. How do these other subspecialties, how do they relate to pediatric orthopedics? And that's why we're here. Only 2 of the speakers are actually pediatric orthopedic surgeons. So I'd like to introduce Dr. Collins. He is a pediatric orthopedic surgeon with CVU Orthopedics. He graduated medical school in 2010 from Texas Tech University, which he will tell you about. He successfully completed orthopedic residency at Rutgers New Jersey Medical School of Newark, and he earned his fellowship at Orlando Health and Arnold Palmer Children's Hospital. He has multiple areas of expertise, but in particular pediatric trauma, pediatric sports injuries, as well as treating spinal deformities, congenital and syndromic musculoskeletal disorders, pediatric hip dysplasia, and foot disorders. He is a huge part of our team. I'd just like to introduce Dr. Collins.
Right. How's everybody doing today? Thank you for coming out. We have a number of interesting topics to go over today, and hopefully we'll keep you engaged well into the wee hours. At the end of the day, hopefully we'll have a few questions after each of these topics, and we'll be able to have a little bit of time to go over them as well. Well, without further ado, why don't we introduce our first speaker here? I believe it's Marina Kirsman. Is that correct? Yes. So Marina is going to give us a talk on pediatric neuromuscular disorders and, most importantly, what not to miss. In this case, Marina is a pediatric neurologist at Jersey Shore University Medical Center, an assistant professor at Hackensack School of Medicine, I believe, and did her medical school at UMD&J and her residency, I believe, and training in neurology at Nationwide Children's Hospital. Hopefully I got all that right. You want to come on down? Let's get started.
Whatever Good evening. It's a pleasure to be here. I've worked very closely with our orthopedic doctors here, including particularly Dr. Haynes, as we share a lot of patients. So tonight I'm going to be talking about neuromuscular, what not to miss. So my objectives: identify findings on history and exam of neuromuscular conditions for further evaluation and referral to us in child neurology. Review the presentation of several pediatric neuromuscular disorders, which can present in the orthopedic practice as well. Discuss more recent advances in the treatment of some of these neuromuscular disorders. This is not an exhaustive list of neuromuscular conditions that we'll present to the orthopedic doctor, but some of the ones that actually have time-sensitive treatments, as well as the more common ones that can be seen in the joint practice. What is a neuromuscular disorder? Any neurological disorder that affects the muscles, nerves, and neuromuscular junction. Etiologies: genetic, infectious, autoimmune, injury, or idiopathic. So clinical history red flags of a neurological disorder. Some of these are relevant both to peripheral, or what we call neuromuscular conditions. Some of them are more general for neurological disorders. So bulbar symptoms, such as trouble swallowing, would be very particular for peripheral or neuromuscular condition. Breathing difficulties, global developmental delay, seen in both central and peripheral conditions, regression, loss of milestones, weakness and falls, recurrent episodes of rhabdomyolysis, be concerning with particular neuromuscular conditions, description of neuropathic symptoms, certainly more concerning for peripheral neurological disorder, and a family history of neuromuscular conditions and early loss of ambulation. Exam findings of neuromuscular conditions. So along the lines of bulbar symptoms, so cranial nerve abnormalities such as ptosis, hypotonia, which can be nonspecific, weakness, particularly the proximal muscle groups, absent or decreased reflexes, this part is very important, contractures, fasciculations, muscle atrophy, abnormal sensory examinations such as touch, pain, vibration, or proprioception, and skin changes in the distal extremities, and abnormal high arches. Okay. So first case, funny gait. 3-year-old boy seen by actually me in neurology for chief complaint of gait abnormality. Normal early developmental milestones and walked at 1 year of age, but per mom had always been slower and more awkward in his gait than his peers. Around 2 years of age, he lost the ability to squat and stand up, but was still ambulating. 4 months prior to seeing me, he was seen by 2 orthopedic specialists. Leg and hip x-rays are normal, and he was diagnosed with femoral anteversion. And so these are subtle presentations of some of these neuromuscular conditions. So what could be going on? All right, so motor. What was his exam? He had moderate truncal hypotonia. He was getting up using a modified Gower's maneuver, able to do only 1 jump, but lands on stiff knees, unable to squat. Reflexes, the upper extremities were normal, patellar and Achilles were completely absent, and there was no clonus. Gait, knees were locked in, slow waddling gait, not wide-based, partial pronation when trying to run, and difficulty with proximal lower extremities. Okay. So this is not my particular patient, but this is a good example of the walk. So I'm actually going to show it again. So if you notice, he's not lifting up his feet much. All right. So this child, based on genetic testing and normal muscle enzymes, ended up having spinal muscular atrophy. He had, he had 2 pathogenic variants in SMN1 gene, causing a deletion of the entire SMN1 gene. He had 4 copies of SMN2, which I'll go into the genetics a little bit later, which help to produce spinal motor neuron proteins, which are crucial for motor function. He was placed on treatment, medication called oral risdiplam, which helps actually to produce the missing SMN protein with improvement in the ability to jump in clinic, timed walk, and stepping on and off the scale. In fact, I had actually seen him coincidentally just yesterday, and he is doing great with our physical therapist, as well as certainly improvement in the clinic, although definitely still areflexic with deficits. Okay, so what is spinal muscular atrophy? It is the most common genetic neuromuscular disorder in children. It is to a degree neurodegenerative, all right? So type 0 is very rare, and children either don't survive or, unfortunately pass away shortly after birth. Type 1, and I'm going over the natural history for these children, not what occurs now with recent treatments. Type 1 is the most common presentation. These are children who are identified in the first 6 months of life, but usually during the first few weeks of life because they have significant hypotonia with normal mentation, and they are noted to be having respiratory distress, bulbar symptoms, and they will have areflexia. Okay? The natural history is that these children will almost universally require respiratory and feeding support and will pass away before the age of 2. Type 2 SMA. So these are what we call our sitters. These are children who present usually between 6 months and 18 months of age. They will achieve the ability to sit, but can often go backwards in their development and lose that ability. A fair portion of them will need respiratory support, and about 70% unfortunately pass away before the age of 25. All right? So SMA type 3, which is what my patient has, is divided into 2 types. One is type A, which is diagnosed between 18 and 36 months. And both of these are walkers, right? So these children achieve the milestone of being able to ambulate, but have, unfortunately, the ability to lose that ambulation over time, sometimes in adolescence. They will also have proximal and axial hypotonia and areflexia, but not to the degree that the SMA type 1 and 2 do, as seen in the fact that my child had preserved reflexes in the upper extremities. Okay? These children have normal lifespans, but as I said, may lose the ability to ambulate. Some require some respiratory support, but most do not. And type 4, these are, again, much more rare and usually present in adulthood. After the age of 30, they're able to ambulate, but some in older age may lose or get worse in that ability. Okay? They do not require respiratory support. Okay? So how do you reach the diagnosis of SMA? Fortunately now, the newborn screening in New Jersey started on January 31st, 2022 to include the screening for SMA, and all states started screening in January of 2024, but can miss about 5%. You can do a genetic panel looking for missing copies of the SMN1 gene, so the spinal motor neuron gene, on chromosome 5, and the number of copies of the SMN2 gene mean a milder severity. So the more copies of the SMN2 gene, which also produce that protein, the milder the phenotype. So that's actually how you also determine whether a child has SMN1 or 2 or 3. So my patient had 4 copies of the SMN2 gene, which went along with his phenotype and meant SMN type 3. Okay? So just kind of going over the reflex pattern a little bit, there's loss of reflexes, proximal earlier than distal, so patellar before the Achilles, and lower versus the upper limbs. So the lower reflexes will go before the upper limbs. So sometimes SMA can have preserved upper extremity reflexes, but loss of lower extremity. Okay? So the reason I brought this case up first is that the treatments that we have now, I would call them to be revolutionary in this field. And early treatment is crucial because there's 3 treatments available now, and I'll go through all 3. But the earlier that they are administered, the better for the regeneration of the SMN protein. They are very expensive. We're talking about more than millions of dollars. And the studies have shown across all 3 treatments that there's marked improvement in motor milestone and ventilator-free survival on all 3 of these treatment groups. I'll talk about all 3 treatments. So there are children with SMN type 1 who, as I said, passed away before the age of 2 who are now walking. And these treatments have come out kind of to the general public in the last 5 years, so we don't have all the long-term data, but they're walking, okay? So there's 3 treatments, okay? One is the enzyme therapy. So that's the Zolgensma. That's actually an intravenous infusion. And what it does is it replaces the mutated SMN1 gene with the idea that you should be able to produce the normal protein. Now, over time, we have found these children do still have motor deficits, all right? But it is delivered via an adenovirus vector, and the earlier that you deliver this treatment, the better. It is approved up until age 2. There's also Spinraza, which is injected into the spinal canal, and what it does is it produces the SMN protein by increasing it from the SMN2 gene. That's a backup, right? That's a backup gene that we have. And Evrysdi, which is risdiplam, which is what my patient is on, is an oral version. It does the same thing, SMN protein production by the backup SMN2 gene. Okay? And so we're still in the exploring phase of how these children do in 10, 20, 30 years, but so far all of them have marked improvement in motor milestones and ventilator-free survival. All right, so case 2, fat calves. 3-year-old boy with running difficulties. Again, kind of similar to last complaint. On exam, he has proximal weakness, again, kind of similar. Calf hypertrophy present by diminished reflexes throughout and a modified Gowers maneuver. He has a family history of a cousin with cardiomyopathy, and as part of the initial workup and a suspected peripheral neuropathy, checked a CK, and it's 100 times greater than normal. So these are just some photos of what the calf hypertrophy can look like, and the lordosity can get along with it. Okay. So this is a presentation of one of the muscular dystrophies, Duchenne. Duchenne and Becker are X-linked recessive dystrophinopathies inherited from the mother, although up to 30 of them can be de novo with no family history. Duchenne is an early onset and the more severe, between 2 and 5 years of age. Progression is moderate and slow to moderate, and then treated children are wheelchair bound by 12. And CK is extremely elevated, like 100 to 200 times normal. Becker onset is in late childhood. Progression is a little bit slower, and treated children still wheelchair bound, many of them by 15 years of age. CK is only about 10 to 15 times normal. Both are associated with dilated cardiomyopathy, heart failure, and arrhythmias. The diagnosis is not on the newborn screen. The diagnosis is clinical, creatine kinase, and genetic testing for the DMD gene, which produces the dystrophin. Okay. So treatment. So you have steroids, which have been shown to prolong ambulation, but do come with significant side effects that all steroids come with. All right, there's supportive care. And now there's also gene therapy, which I would say is not as really curative as what we have seen as SMA, but certainly has shown improvement for a portion of the children with Duchenne. So what it does is there's exon skipping for those with certain exon mutation in the dystrophin protein. Okay, about 30% of boys with DMD currently, so a significant minority, allowing more dystrophin to be produced. It has shown to have improvement in some of the functional outcomes, not all, but it is not curative. But definitely still very exciting. Okay, so case 3, ankle sprains. So this is a 16-year-old girl with normal birth and early developmental milestones presented with frequent ankle sprains. Further history reported difficulty running like other children and numbness in her feet. On exam, she has normal strength, except distal ankle dorsiflexion and eversion is slightly weaker, 4 out of 5. She has absent ankle reflexes, otherwise normal, and she has decreased sensory loss to pain in the foot. She has very high arches. Okay. So what do we have here? So Charcot-Marie tooth. So I'm bringing this one up because it may often present to the orthopedic practice before it comes to the neurologist. So this patient would have the most common type, which is CMT1A, based on genetic testing showing duplication of PMP222 gene. EMG in this case would show slowed motor conduction velocities, and genetic testing often precedes EMG in pediatrics now because you may often require sedation for such a study. It's in about 30 to 50%, and it's autosomal dominant, so you may often have a family history. Things you may see: falling, foot drop, onset within the first 2 decades, pes, cavus, hammer toes, occasional proximal weakness, and sensory loss using stocking glove distribution. There are many other forms of CMT. They're less common, but 1/3 of CMT presents in infancy and childhood with multiple other presentations, including hearing loss and other sensory and motor issues. Okay. So there's just a picture of what the foot may look like. And as opposed to the first two, there are no curative or treatments that will modify the disease process, but I'm bringing it up because there's definitely supportive and prognostic information that can be provided to the family. They're often seen by orthopedics. Physical therapy or age-appropriate activities such as swimming or dance in younger age can be helpful. And they can also help with good compensatory habits to improve gait and function. Some of them may require night bracing. That would be something that orthopedics, I'm sure, can also weigh in on the treatment modalities for that. Okay, so limb-girdle muscular dystrophy. We already talked about 2 of the types, but I wanted to go into detail about what else may present. So this is a congenital disorder characterized by progressive and degenerative weakness of the shoulder and pelvic girdle muscles, starting in childhood to late adulthood. So if you look at the picture right next to it, this is a picture of 2 siblings who were diagnosed with this type 2A, which is actually autosomal recessive, which is unfortunate, but presenting around 1 year of age. And, I think they're trying to show that both of them have that shoulder weakness. You can see that droop, as well as in the pelvic girdle. And then below, you see more of the distribution shown to you on a diagram of where that weakness is. Okay? But the transmission can be all different. So there's autosomal dominant, which is associated with type 1, autosomal recessive, which is type 2A, which you see in the picture above, and then what we already talked about, which is X-linked, which is Duchenne and Becker. The ones not Duchenne and Becker, CK is actually normal or only mildly elevated. So this, if you're looking for the clinical laboratory findings for this, you have to have it in your mind for someone who has this distribution. And diagnosis via multi-gene panel. And if not, biopsy can sometimes be helpful, but it's really not first line anymore because it's not always specific. Treatment is supportive, steroids, and then we talked about with Duchenne, there's exon skipping. So, facioscapulohumeral muscular dystrophy. So this is a so the pictures are different, so I'm kind of discussing a little 2 cases, but 17-year-old boy with right shoulder pain and weakness in lifting his right arm above the shoulder presents to the orthopedics practice after being hit to the right shoulder. So I would think that this may be a common complaint that could come in. All right. On exam, there's no facial weakness, which we'll talk about more, but there's right greater than left, right shoulder is lower at rest. But interestingly, there's winging of both of his scapula, right more than left, and difficulty with right shoulder abduction. So based on kind of the winging, suspecting potentially something else going on, an EMG is done on the right, which shows signs consistent with long thoracic nerve injury, which is consistent potentially with the injury that these adolescents sustained. But the left periscapular muscles showed chronic myopathy. The genetic testing then showed FSHD type 1, which is actually 95% of the cases. And with this, you have typically progressive weakness that affects the face, shoulder girdle, and upper arms. So if I were to meet this patient in, let's say, 20 years, it'd be very likely that they would have facial weakness notable on exam. Okay. There's almost no respiratory cardiac involvement, or it's not common, but 20% of them can be wheelchair bound by about 50 years of age due to the weakness that they have. Unfortunately, there's no disease-modifying therapies, but treatment is supportive. So another example of a younger child with this is what I have here in the picture. So this is a 6-year-old boy presenting with early onset of FSH type 1, FSHD type 1. And you can see that early onset, you already see the facial presentation. He has right apoptosis and facial weakness. You can kind of see the droop of the mouth as well as the ptosis on the right eye. He has significant bilateral winging of the scapula and difficulty raising both arms above shoulder height. This child also had a hyperlordotic back, and he had bilateral hearing aids, so sensory hearing issues are also associated with this condition. Okay. All right. So I went through just a couple of the neuromuscular conditions that have disease-modifying therapies or that are more common that presents to both a child neurology or orthopedic practice. So look for signs of neuromuscular and peripheral disorders in the evaluation of pediatric patients. Think about those clinical history signs that I brought up in the first slides. And think about those exam findings, particularly looking for the distribution of any weakness in a child or adolescent, and looking for reflexes. Spinal muscular dystrophy and dystrophinopathies specifically have newer agents available for therapy, which particularly even in SMA are disease modifying, and earlier administration is better. Okay, so these are my references. Okay.
I think they'll turn it on. All right.
Is this on? Wonderful.
If anybody in the audience has a question, just give a hand up, and then you can present your question. And if not, Dr. Collins will so.
While we're waiting, I actually have one question, or actually it's a two-part question. It's more kind of in a general sense. One, how do you actually diagnose hypotonia in a toddler? And more importantly, when should we actually refer to neurology for hypotonia? In my practice, I see, at least on a weekly basis, 1 or 2 toddlers for delay in ambulation and hypotonia, and most of them probably don't have a neuromuscular condition, but it's tough to convince the parents, and it's really hard to get an objective finding of what really is hypotonia when you have an uncooperative toddler. What's your experience in doing that?
That's an excellent question, and I was actually reviewing this with our child neurology residents. It's much easier to some degree to pick up hypotonia in an infant. You pick them up, kind of seem floppy, they slip through your hands, or you put them in horizontal position, and they don't scrunch up their arms and legs as you would expect. It is harder once you get into that toddler age, 18 months to 4 years of age. So generally what I look for is their ability to do things that require truncal support. So I will often put the toddler on the floor and have them try to get something from up above. So if they are requiring kind of their hands significantly, or doing what I would call modified Gowers or Gowers maneuver, that raises red flags. The other thing to look for is reflexes. And I emphasize this, and I know that it can be tough, but one should always, I think the presence of reflexes or the absence of reflexes, I think is a minimum that I think can be picked up. Sometimes it's difficult to pick up when there's decreased reflexes if you're not checking them on a continuous basis. But that's why I always recommend that we having a proper reflex hammer in the office.
Challenging in some of our offices.
And I always give some extra to those who are rotating through with us, because that certainly makes it easier to pick up. But watching a child kind of get up from the floor, having them actually kind of watching them climb onto a chair, those are the kind of things one should see to pick up tone abnormalities. And then the other issue is I don't think it's ever wrong to refer a child who you suspect to be hypotonic, and maybe is just what we call benign essential hypotonia, will grow out of it, for a neurological exam with a child neurologist. And we may be a one exam and there may be nothing else for us to do, but particularly in the setting of global delay, there may be other things for us to test for.
All right, 1 second. Just tell her.
Hi, I'm Colleen. I'm a physical therapist. I just had a question because the spinal muscle atrophy treatments, the revolutionary ones, are so expensive. How have you been at getting them covered, and what is there something that people can do to get them covered quicker for like patients? Or are you having any difficulty with that? Like for parents and
So the therapies are covered by insurance.
that's good. Oh, that's great.
Yes. That's one of the reasons that it is on the newborn screen. Because you had to be on the newborn screen, you had to prove that their treatments are disease modifying. That's why, to some degree, the Duchenne's treatments, some of that testing is harder, but also not all neurological conditions that have some disease have some therapies for it on the newborn screen. But SMA now is, because it does alter the progression of the disease, and it is covered by insurances. Certain states better than others. Sometimes one has to fight with insurances, particularly how long the approval will take. Obviously, time is more intensive in a younger infant, but they are supposed to be covered by insurance.
That's great. Thank you.
That's a great question, and I really think it was a wonderful presentation, Dr. Chrisman. As I walk over to the next person, I do have a question also. Do you think that we should be expanding the genetic testing for newborns?
Just to clarify, expanding it to include other kind of neuromuscular conditions, or?
Yeah.
So I think that's a tough question, because if they do not have a disease modifying therapy, I think it would be harder to argue for that. And you do get kind of false testing, and so I think it would have to be that there is a disease modifying therapy available in order to add that screen onto the newborn screen.
Well, thank you.
Good evening. Wonderful presentation, Diane Anthony, school nurse. I had a question regarding the pharmacological therapies, and it's great to hear that insurance does cover it. Now, are they lifelong therapies? Are they therapies that you monitor the dosaging as the child develops? Can you please go into a little bit more specifics regarding that?
Sure. So the gene therapy is a one-time intravenous infusion, and it is supposed to be a one-time therapy. Okay, so you don't have to keep repeating that. The intrathecal therapy does have to be continued, and initially there's time frames. You do it once, and then you do it in a month, and then you do it essentially every couple of months. You have to continue to do the intrathecal injections, and that is invasive. All right, but there have been good outcomes in terms of motor stabilization. One has to understand that a lot of these clinical trials were happening at different times, but sometimes simultaneous. So that's how all three drugs similarly came to market within a couple of years of each other. And then the oral medication works similar by increasing the SMN2 protein, the SMN production of the protein, and has to be taken lifelong, as we know at this time. Now, there are some studies looking into combination of therapies, because even in the gene therapy replacement, while some of the children are able to achieve ambulation and are free of respiratory support needs, for example, at 2 or 3 years of age, they certainly do have motor deficits. So I think it is very much an open question, and one that I don't know that is necessarily covered by insurance to be on combination therapy, for example, to receive the gene therapy and then to be on oral risdiplam, for example. But there are clinical trials that are going on. Did that answer your question? Okay.
I think we have one comment online about the difficulty of getting these medications authorized. Sounds like there are some opinions, perhaps, that there are some difficulties with some insurances, I suppose, as opposed to others.
There are, and I think some of the insurances in different states, I mean, their parents definitely have had to lobby their legislative bodies sometimes in order to get the medications approved. So it's not all smooth sailing, but I think as more children are getting treated and outcomes are coming out, I think it's becoming easier, but certainly it does take time, particularly time being more sensitive in a young neonate. And some children are treated pre-symptomatically. If parents know about the diagnosis pre-symptomatically, the idea is to treat the newborn as soon as feasible once they're born. There's some baseline testing that has to be done, but yes, there can be delay in terms of getting approved with some insurances versus others.
Okay. Well, thank you very much for giving the talk, and
All right.
let's move on to the next. We up? Yeah. So our next speaker is Dr. Moses Olorunsola. I believe I'm saying that correctly. Most people, I think, call you Dr. Moses, if I recall. In any event, he's going to be giving us a talk about pediatric limp. Moses is a board-certified pediatrician for both Hackensack Meridian as well as PM Pediatrics. He graduated from medical school at American University of Antigua and did his pediatric residency at Rutgers and JMS. He's been serving the community around Ocean Medical Center and Southern Ocean Medical Center for about a decade now. So why don't you come up and teach us about pediatric limps?
Hi, everyone. They call me Dr. Moses, but it's Olorunsola. No, you get like a B minus. So, when I was given the injunction, I would say, to do a topic, because when I graduated initially, I did straight emergency room for about 5 or 6 years before I started doing primary care. I thought, what angle should I come at this topic from, whether it's the ER or primary care? I figured the primary care, for me, was a bit more challenging, so I figured I'd talk about that, because the ER, you come in, I do an x-ray, follow up with ortho, and that's the end of it. But from the primary care standpoint, one of the more common things that we see that gives me fits is limp, when the child comes in for a limp presentation. And I said, is it a primary care nightmare simply because you're almost stuck all the time in terms of what to do based on why the kid is there? Do I just have you follow up with our ortho friends? Do I send you to the ER? Do I send you to urgent care? Do I start the workup? So we're gonna essentially talk about that now. I wasn't here early enough to figure out how to change the slides on this. Just push this guy. Oh, I'm good. So I have no disclosures. So the goal of today is basically, if there's anything I want you guys to take away, is really to talk about how important a history and presentation is and how important a physical exam is. And that's really what we have at our disposal from a primary care standpoint, is that, but it is so important that that's often what guides us and leads us to what, the next steps are and the final outcomes. So what is limp? Essentially, it's an abnormality in gait right? That's caused by pain, weakness, or deformity. The pain could be from an infection, a fall, something unknown, weakness from something congenital, from some genetic issue. And so even though we're talking about a kid coming in limping or parents saying, oh, my child limps, in certain situations, especially in our younger ones, the toddlers, maybe they hurt themselves or something happened. They limped once at home and never give you the opportunity to actually see them limping in the office. So these kids are usually, carried in by their parent, and they have this fear of putting weight on. One of the videos that Dr. Krisman showed where you see the kid walking, we don't get that at the office because the kid is screaming half the time, so I can't even look at your gait to see, what the issue is. So sometimes just not being able to bear weight is also one of the presentations that we see. So I'm gonna spend a little bit of time on this slide. This is, again, the bread and butter of medicine, history and physical, right? So the kid comes in with either a presentation of limp or the parent brings the child in for limping. And we're just gonna go through, stuff that we all know, right? In terms of the history, the age of the child, because it's primary care, I know your age already. These are patients that we've been following for weeks, months, years. So the age is very important, and some of the diseases we're gonna talk about, I've broken down in an age presentation. So the age of the child basically helps us kind of narrow down or expand what your possible diagnosis may be. So a child comes in limp. So right in my head, my differential is a whole textbook, right? And then I see the age, that differential has to shrink in some way, shape, or form, because there are things you're gonna see in a toddler that you're not gonna see in a 13-year-old. So the age has kind of limited our differential a little bit. Now, inciting factors, surrounding circumstances, this is where we get into, the interrogation of it. What happened? Was the child playing on the play yard and then fell? Was there a viral infection 2 weeks prior and this just started all of a sudden? Was there, some sort of stomach bug that happened and then your kid started limping? Was there, you're literally just going question after question after question. If it's someone who is maybe older, an older teenager, I may even want to ask about a sexual history, gynecological arthritis. So there are different questions and surrounding factors that you're going to be asking just to help kind of reduce the number of pages in the ortho textbook that you're looking at to say, why is this kid limping, right? The length of time, how long has it been going on for? Has it been going on for weeks? Has it been going on for a day? Has it been going on for a year? Is it chronic? Is it acute? Is it on and off? And then some of the associated symptoms, right? Does the child have an acute fever at the time? Is there abdominal pain as well? Does the kid have back pain as well? Does the kid have urinary symptoms? So you came in limping. Why am I asking all these questions? And we'll get into some of that because the reason for your limping could be answered literally in you giving me, the answers to some of those questions. Right, and then we talked about the time, chronicity of the pain, and what are some of the aggravating and alleviating factors? Does the pain get better with activity? Does the pain get worse with activity? Is the pain worse at nighttime or the pain, is worse in the morning when you wake up? Does taking Motrin help the pain? Does resting help the pain? So all of those questions that we're asking, and I honestly thought emergency room, working in the ER, I worked in Newark, UMDNJ ER for a few years, then, Southern Ocean, OMC as well. I thought working in the emergency room was different and difficult, right? I worked in Newark, we dealt with kids that, even though we have a trauma center there, gunshot wounds, stabbings, different things like that. I've pronounced so many kids, unfortunately, just in those few years I worked in the ER. But when I tell you primary care is probably the most difficult challenge I've ever had, it is, because you have this history, we have all of these things in front of us. Now I have to sit there and determine what is the next step? How do I go about this? I have to put my thinking cap on. Who do I call? I try not to bother Dr. Haynes too much. He probably hates that I have his number, but it's always good to phone a friend, right? Now, the physical exam is extremely, extremely important. And I contrast it in my ER days. If you come in for limp, I'm probably looking at your legs, doing some imaging, and having you follow up with ortho. But when you look at the presentation, right, and you're asking all these questions, you're not sitting there and typing and then looking, you're literally trying to process and reduce that differential as you're getting the answers back. All right, this wasn't traumatic, so we can maybe rule out fracture. This wasn't this. So you're going through reducing your differential, and then maybe you hear another answer, and then it expands again. So all of this is happening in your head while you're talking to the family. Then the physical exam, extremely important, especially for, the younger kids. You want to examine them as close to naked as possible, because one thing the families do is they come in with a diagnosis. The mom says, oh, I think, Johnny has knee pain because he keeps grabbing his knee. And then that leads you into looking at his knee, and you may actually miss something. So because limp can, other diseases rather, can present as limp, you want to be able to examine the entire child. Just 2 weeks ago, I had a kid coming in limping, and it turned out that he had epididymitis, which is inflammation of the epididymis, which is something that's, hugs the testicle and the scrotum. But the kid came in limping because the mom saw him walking funny. So if I just examined his leg, I would have said, I don't know what's going on. Maybe he fell, come back in a week, right? But then we took his pull-up off and we examined him. And once I examined his scrotum, kid screamed in pain. So in my head, I'm like, oh my God, he's got torsion. But I'm like, no, this is not torsion. But bottom line, we got an ultrasound and it confirmed that he had inflammation of his epididymis. But again, why it's very important to examine the whole patient. Oh, I think I missed something. Well, something on there talked about gait evaluation. Basically, watching the way the kid walks can also help you with kind of narrowing down the diagnosis, so to speak. So what next? Now that you've done your history, you've gotten all the questions answered, you've done your physical exam, what comes next? So typically, right, you have your differential. You have to have a high index of suspicion to say, hey, this is the way I'm leaning towards, this is what I think it is. Sometimes it may be obvious, right? I was playing, I fell, and now my leg hurts. Or, the mom saw him doing this, or the father saw him do that. So sometimes it's very obvious. But I'm talking about those situations where maybe there's no direct story. There's a lot of thinking involved. So that history and physical is what helps you determine what you do next. Now, there may be situations where I'm like, you know what? I should be able to at least start the process, because I don't think this is something acute. This is something emergent. This is something that I need to send to the ER. Can I perhaps do imaging myself to see if they even need to go to ortho? Can I perhaps do some labs to see maybe this is a rheumatologic condition? Maybe this is some sort of juvenile arthritis that I need to refer to, not ortho and maybe a different department. So what am I doing? So once you've gathered all your facts and you've done your physical, you have to make a decision. We have to do something. Right, am I sending you to the urgent care, the ER, or am I taking care of it myself? So we look at any age group. I don't know why my toes are shivering. Typically, I get the shivers when I'm doing one of these things, but I've never had my toes shiver. Sorry about that. So any age, right? You could have an abdominal issue. You can have a pelvic abscess. You can have appendicitis. There's a walk my kids with appendicitis do where they come in kind of doing one of these things. So they walk in looking like they're limping, but something like this, limping is typically not the presenting complaint. It's abdominal pain, maybe nausea, vomiting, fever, and things like that. But just to kind of let you know that a kid limping could be from an infectious process going on in their abdomen, which is why the physical exam can't just be limited to the leg, especially those younger kids that can't say, my belly hurts. So you may have examined the leg and found nothing, and then you push on the abdomen and the kids start screaming and crying, all of a sudden your differential changes, right? Again, some things are a little bit more obvious if the kid has a blister on their skin, or they have, a plantar wart under their foot, hand, foot, and mouth disease, something that we see all the time. The rash on the bottom of their feet sometimes causes them issues in walking. So these are not orthopedic conditions, but these are conditions that present like maybe they should be going to ortho. So making sure we do, again, you're going to hear me say over and over again, the history and physical, making sure you do a thorough job in that can help navigate some of these issues. A foreign body, again, very straightforward. You see the splinter under your foot. I do that a lot in the office. We have these like little splinter out things, that we're able to do in the office to help some of these situations. Again, fractures. Typically, I had an issue maybe 3 weeks ago where mom said they were at the play yard, the kid came down the slide and maybe hit mom's knee a little hard. Knocker was, and the kid started playing, but then started limping and refused to bear weight again. So mom took him to urgent care. A lot of times the fractures don't come to us, right? Because they know I don't have an x-ray. When parents think that the kid may have broken something, they went to the urgent care. Urgent care did an x-ray, no fractures. And then maybe 4 days later, mom brings the kid and says, he's still limping. So exams are harder in the younger ones because they want to be held by mom, screaming and crying. So you have to get creative in the primary care world. Cell phones are not good, but they are very good. All right, so this is where I tell the mom, please put something on, Cocomelon, whatever it is, just to distract the child. So because the story, that whole coming down the slide story, it's like toddlers' fractures. That's how they commonly happen. So I basically start examining the kid as he's distracted and going on the toes, pushing. I see no signs of swelling, nothing. And as soon as I get to like his, proximal tibia and I push a little bit, he's watching the Cocomelon and all of a sudden with a pacifier in his mouth, and then he pulls back his leg. And I was like, whoop, there it is. Mom's like, what do you mean? I'm like, I think he may have a toddler's fracture. I continued because, you have to do a thorough exam. Continued all the way up, checked his hips and everything. And I went back to that side again and I got the same response. So I said, what do they do at the urgent care? Well, when he fell, I thought it was his ankle. So I went to urgent care and I said, I think my kid hurt his ankle. And they did a foot x-ray and an ankle x-ray at the urgent care. And it was obviously negative. So instead of sending him back to urgent care, because now I don't trust them, I said, let me just do my own stat x-ray. So I did a tib fib, and lo and behold, said it was negative. I thought I was good at this stuff. So I had the mom come back the next day. I examined the kid again. It was the same thing. I don't think if this was a text to you, it may have been, but I told mom I said, just please go to ortho, because I didn't get a chance to, again, look at the x-rays, send him to ortho. I think they came to Seaview. And the mom calls me back the same day and said they did another x-ray there, and the doctor showed me the fine line on the tibia. He does have a toddler's fracture, and I think they splinted him, and blah, blah, blah. And I was like, whoa, great. So I called the radiology department because, not to yell at anyone, but, look at it again, and then there was a reread, and yes, it was there. So if you're not a pediatric trained radiologist, there are subtle things you may miss. So this is, again, going back to the history and physical, because the parent says it's an ankle may not mean it's an ankle. Because the kid is holding a knee may not mean it's a knee. Just always do your history and physical exam. So that's just a perfect example of where maybe sometimes a fracture may end up in our doorstep. So something like osteomyelitis again, that can happen at any age, right? Bone infection, right? Typically, this comes in fever, chills. There may be maybe a recent surgery happened, or the kid had maybe a deep puncture wound that somehow the bacteria kind of got deep into the wound and got into the bone, and now the child has an infection. So something like this, the presentation, you may see, again, some of those constitutional symptoms, but the presentation and physical exam, you may have bony tenderness. The kids are typically pretty sick. Something like this, I'm sending you straight to the ER because this is something obviously that needs more of a acute management. And then malignancy. A lot of times this, does start in our office because there's typically no story. There's no falls. There's not much of anything besides this, my kid's limping. They complain of pain, maybe at nighttime and different things like that. So those are just examples, osteosarcoma, leukemia, Ewing sarcoma. Those are some of the things that can present with limp. A kid that has leukemia, I had one case last year where it was more of bone pain, but the kid sometimes just refused to walk. But then you look at the kid's history, there was no acute weight loss, but you look at the growth chart and it's like, all right, over the past year, it looks like you've been dipping a little bit. And then the past month, fatigue, random fevers here and there. So I'm not thinking malignancy at that point, but I am thinking malignancy, because remember that differential, it's on there. So what do I do with a kid like this that's kind of stable, but I know there's something going on? So this is a situation where primary care comes in handy. Here is a script to go, get blood work done. If I do an exam on you and you have some sort of bony pain, I'm going to do an x-ray of that part of your bone. So blood work comes back and it shows, you have blasts and this and that. I'm sending you to the oncologist, right? Hemonc, I'm sending you there. If I see something on the bone, I'm calling hemonc, I'm calling ortho at the same time. Here's what I have, but the journey begins in primary care. So it's very, very important to history and physical, differential, just to know how to approach it. Post-infectious arthritis, please let me know when I'm running out of time because I tend to talk too much. Septic arthritis, again, Lyme's arthritis, another thing that we see commonly in the office. And very, very rarely do you hear of a tick bite. But it's the kid that, hey, this knee was swollen, last month, and then, kid was playing around a lot, so we thought he fell. But then 2 weeks later, a month later, the other knee swollen. So a kid comes in like that. Again, we had this case where the kid came in limping, and you look at the knee swollen pretty good, right? No acute injuries. But part of my history was, do you live in the woods? And they said, yes. Any recent tick bites? No. Any tick bites? Not really. We're always very vigilant about it. Even though there was no tick bite, Lyme's arthritis still has to be on your differential, especially with that kind of history. So, but it wasn't septic arthritis level, right? It wasn't like fever and crazy tenderness, because if I'm worried about that, again, I'm sending you to the ER. But that worry was kind of there, because that's why I said primary care nightmare, because I'm like, you kind of meet certain, check off some boxes for septic arthritis, but I don't know. Now, because you told me that it has happened before and got better, my septic arthritis differential kind of got bumped down a little bit. So I took the brave step and said, you know what, here's blood work, try to get it done. His knee mobility and exam wasn't that terrible. He wasn't in crazy pain. So I wasn't really thinking septic arthritis, even though I was still scared, sending him to go get this blood work. Came back positive, his Lyme titers were through the roof. So I was confident, Lyme's, treated him, had him follow up with ID to make sure there's nothing else I was missing. But again, going back to a simple history to help me navigate, what next steps I would need to take. And viromyositis, something we see a lot, especially nowadays, fever, flu season coming up, or we're in it already. A lot of times kids come in with fever, really high fevers, and parents saying their legs hurt, they're not walking, they're limping. Typically something like that, I do my full exam, but because of all those other things, there's really not much of a bony tenderness, but you may have like the calf muscles may be a little tender. do a flu test, comes back positive. All right, this is probably, a viral myositis type picture. Again, there's got to be a close follow-up. Give him some, pain control, treat the fevers, and this should improve over the next few days. If that happens, maybe it may even just be a phone call over the phone. Oh, he's running now, he's walking. I'm confident that, that was managed appropriately. And then, so some of the more age-specific things. Now, you may see some of these diagnoses in 2 age groups just because it can cross, but in our younger toddler kindergarten group, transient synovitis, very, very, very common in our practice. And that's the story of a kid that had some sort of upper respiratory infection 1 to 2 weeks prior, and now with no injury or anything, the kid is limping. They're still able to walk and bear weight, but they are favoring one side. So they come in because of limping, not because of a cold. But once I do my exam, I examine the child, see the way they are, I don't see anything concerning on exam, not so acute. Usually when I externally rotate the hip, they may have a little bit of wincing or they may hurt a little, but everything else looks fine. So I have the history that the kid was ill 2 weeks prior. I'm like, this looks like and is most likely a, transient synovitis. I think it's also called toxic synovitis, but if I tell a mother that their kid has toxic synovitis, they may not come back to practice. So the word transient, and I focus on the word transient, this is something that will get better. I typically give it about a week, even though the books say it can last longer than that. And I have referred, I think, one kid in the past year or so to ortho because we were 10 days into it and the kid was still limping. So I refer them to ortho and it turned out to still be transient synovitis. Even 2 weeks later, eventually the kid got better. Vaccine administration, you get a shot, you're gonna be limping for a minute, so that's something very straightforward, but typically with something like that, the hips are fine, the joints are fine, everything is good, but you just got a shot 2-3 days ago and that's why you're limping. Hand, foot, mouth disease, we talked about. The toddler's fracture, again, we talked about. It's typically not a really crazy injury. It's like a mild rotational injury to the lower leg, sometimes a mild fall, and that x-ray is one of a toddler's fracture. So that's easily missed, right? Like you look at it and everything looks good, but you gotta zoom all the way in sometimes to see it. And also at what point do they do the x-ray? Was it 4 days into it, 5 days into it? So that can also change what the x-ray looks like. Child abuse, one of my least favorite topics. Typically with something like this, it may not be one, sometimes we see this in a kid that's maybe just recently started walking, but it's typically that, spiral femur fracture, because that's a bone that's pretty difficult to break, and in one of the cases we had, the story was, so the kid came in and the parents said that they feel like his leg got stuck in between the slats of the crib and got stuck in there, and now he cries every time we push on his thigh area. It's very rare for a parent to come in and be so specific when they give a history like that. And I say that not that you should be judging every parent that comes in, but typically it's like, oh, I think it's the ankle, and it turns out to be the hip. But I think to myself, this kid I'm looking at, I know the size of the space between those slats. There's no way your leg is getting stuck in there. And even if that were to happen, you're not getting a spiral. Well, I didn't know it was a spiral femur fracture at that point. There's no, how are you fracturing your femur from getting your leg stuck in there? So I asked more questions, and you could tell the answers were kind of up and down. If I did an x-ray and it showed that it was a spiral fracture, a lot of times when child abuse is involved, you may not get a second visit because they're scared, the parents don't want to get caught. So in my head, again, that's why it's important to have a high index of suspicion. When the story didn't make any sense and I examined the kid and the kid was just screaming every time I went to that space, I'm like, listen, this is very, very bad. Even though it's a bad fracture, I kind of blow it up worse than it is. Like, this child has to go to the ER because, they may lose a limb if we don't. So that fear I put in them gets them to go to the ER. Because a lot of times, a lot of times I look back and I'm like, is this someone that I should have possibly gotten, an ambulance for? Because I've gotten cases where I've referred suspected child abuse to the ER and they never went to the ER. So it's almost just to get them there. Sometimes I think, do I get them in an ambulance? But every parent that is going in an ambulance complains that the insurance doesn't cover the bill. So I'm trying to, go back and forth. So I say, listen, I'm calling the ER right now, and I'm going to call them in an hour to make sure that you're there. And in that situation, if I call and you're not there, I'm calling the cops to come to your house because we have a right to defend this children. Long story short, the kid goes there, spiral fracture, and obviously the rest is history, But so child abuse is something that could present as limp as well. Septic arthritis, a septic hip, again, the presentation gives you that vibe that, yes, this kid needs to go to the ER. There's fever, there's tenderness, there's swelling. The exam is very painful, very uncomfortable. So when things literally on that physical exam, when it's one that's just like way over the top, I don't mess with that. That's something that needs to go to the ER because especially if you have those constitutional symptoms of fever, swelling at the site, or you feel like the joint may be septic, you got to refer them right away. And the last on this age group, IgA vasculitis, that's your Hennig-Schlenick purpura. Those kids usually come in with a rash. So that's something that you can tell that is not typically an ortho presentation, but something that is a byproduct of, the IgA being deposited into the small vessels. But that's something that we typically take care of. And based on, blood work and things like that, I probably will refer you to the ER, but typically it doesn't end up in the orthopedic doorstep. Discitis, does the kid have back pain? So you have to examine the back again, especially in those kids that can't tell you my back hurts. So because you don't see anything on a leg exam, make sure you examine everywhere else because the cause may not be there. And fracture, a Salter 1 Harris fracture, Salter Harris 1, yeah, Salter Harris 1. So those fractures they're hard to see on x-rays, sometimes because it's a line right through the growth plate, so high index of suspicion. So some of those, maybe right or wrong, I may have taken care of myself because it presents as like an ankle sprain. So I do an x-ray, it comes back normal, but every radiology read is, although I don't see any fractures, can't rule out a Salter Harris. So I, put the kid in a boot or whatever that you can get from one of those places, and the kid is in it for about a week and a half or so. I have them follow up. They're doing better, great, bye, you're done. So some things like that we may be able to take care of. 5 to 12. Some common stuff, we already talked about this ligament injury. We get a lot of sprains, knee sprains, ankle sprains, different things like that. Growing pains, this is one of those things that we see a lot, and I probably throw around a little more than I should because it's that complaint of my kid, he complains of pain to, his long bones typically at nighttime, and then they go to sleep and they're fine. No issues during the day, but nighttime, not every day, but here and there. And it's a kid that's growing like a weed, so it's one of those things where I'm like, what, on exam, I find nothing. So I'm comfortable to say, hey, it's most likely growing pains. Let's keep an eye on it. If the symptoms become more persistent, they get worse, we can do other things. So something that is a growing pain, so to speak, I typically, again, focus on the physical as long as I'm reassured, follow up if things get worse. Transinctivitis, we talked about that. Vascular necrosis of the hip. So I'm not going to go into big details about all of this just because I'm not that smart on all of these things. So I'm just going to go real superficial. And when I get stuck, I reach out to you. So vascular necrosis, this is your right leg, calf, Perthes disease. I prefer this name because you can kind of figure out what's going on there. So typically this kid's coming with a limp, but it's often painless. They don't have pain, but when you examine them and you start aggravating the hips and things like that, they have some level of discomfort. Again, so a kid like this, I probably start their journey, right? I'm not going to just send them to ortho because I don't know if it's that. So I do an x-ray, and the x-ray, voila, it shows it, right? Because avascular necrosis, it's just the blood supply to the, to the femur, to the head of the femur is kind of shot. And we see this in kids. Two of my kids that have had this had sickle cell. So this is something that you can see in kids that have sickle cell disease as well. Just anything that can affect, their blood supply. So something like that, again, we see it in our office, we do the workup, and then they end up at the doorstep of our orthopedic friends. And the Sever's disease or apophysitis of the heel, this typically, or, calcaneus bone. We see this in kids that play a lot of sports, jumping, soccer, basketball, things like that. This is like an overuse injury. And some of these, depending on how I feel, I might send them to ortho and I know what the outcome is. Sometimes I may just refer them to PT, rest, ice, chill out from the sports a little bit, or just have them do PT, and it should get better with time. But this is something that, depending on how severe it is, we may take care of it from a primary care standpoint, or I refer them to ortho. And in our last age group, 13 to 18, I talked about this earlier, gonococcal arthritis. This is one where I've probably seen twice in practice, but those are your kids that, are sexually active, and maybe obviously they have gonorrhea for them to have this, but again, going back to the whole history and physical, you get your history of sexual activity, you do your test, confirm that's gonorrhea, and then I refer you to ortho, or, treat you at least for the infectious part of it. Ligaments, sprains, tears, muscle strains. And we also see slipped capital femoral epiphysis, or SCFE. We've had 4 or 5 cases maybe in the past year and a half of this, and those kids have the textbook presentation. Typically you see this in kids that are typically greater than a 95th percentile, on the growth chart. So your kids that are overweight, and it's the head, right, of the femur that's kind of slipping off. So you see the x-ray, and I love doing this whenever the x-ray confirms it is. So you draw a line essentially, and the normal line, or where is it? The normal one, right? The kid's right. You see it, how it doesn't, it's supposed to bifurcate, or not bifurcate, when you do the line. So that's one of the things that you see to say, hey, this kid has SCFE, so to speak. Again, that's a surgical fix. So we typically just start it with us, diagnose it with us, and then refer to ortho. And then the last thing on this list, this is not an exhaustive list, but I just kind of threw on there the things that we've actually seen in our office, is the apophysitis of the tibial tuberosity, or Ashkut-Schlotter's disease. Love it. That Sean Connery accent. Oh yes, Ashkut-Schlotter's. So it's common, again, in our kids that are growing, or sports kids. This, I never send these kids to ortho. This is your typical rest from the sport, ice. There are these knee braces that they wear to kind of help with this. This is one of those things that is more of a chronic thing and should get better over time, but it's basically inflammation of the tendon, the attachment from the femur to the tibial tuberosity. Last slide, I'm almost done. I need water, so management follow-up, what happens next? It depends on the diagnosis, right? It depends what your differential is. So my safe discharge, and what I mean by safe discharge, those people that we keep, those people that I don't refer out. Typically there's no fevers. If I do an x-ray, it's normal. The pain can be easily managed with oral anti-inflammatories, or just oral pain medication. Toddler fractures, that shouldn't be on there. We kind of take care of it, but a lot of times we would send them to ortho, obviously, to be splinted if necessary. Those kids that do have a fever, but based on the exam, there are no concerns for an acute joint. So it could just be a viral myositis. So those kids, I kind of just do a close follow-up with, where I think it's just something that should get better on its own. Now, so if the working diagnosis, meaning I don't have a diagnosis yet, but it's something that is not emergent, then I start and do enough to figure out who I'm sending them to, right? Am I sending them to HEMONC? Am I sending them to the rheumatologist? Am I sending them to ID? Or am I sending them to ortho? So because it's non-emergent, I kind of, we do a bulk of the workup from the outpatient standpoint before we refer them out. And last but not least, if the working diagnosis is emergent, septic hip, osteo, SCFE, malignancy. The SCFE one, I'm not going to send to the ER, but I'm going to call you on the same day and say, hey, this is what I have. Tell me what to do next, kind of thing. The malignancies, occult fracture. So child abuse, I'm sending to the ER. Or, if it's something that just needs to be splinted, I may send to ortho if I can get a same-day appointment, or send to urgent care because they can do an x-ray and splint them at the same time. And those are my sources, and the end. Thank you. I go here. Oh, thank you. Thank you. Appreciate it.
All right, I know we're a little pressed for time, but I actually have some comments because I think you brought up a really important point at the beginning of your talk. And we kind of say this in the pediatric orthopedic community in jest, basically, but when in doubt, examine the patient. You can come in, take a look at an x-ray, and walk into a room and tell them what's going on, assuming the x-ray shows something. But there are those patients, toddlers with a syndesmotic rotation that is symptomatic, and the x-ray shows nothing. Even, sometimes you see teeny tiny crack, but 30% of the time you're going to see nothing. But the exam tells you exactly what's going on. Put a cast on, 4 weeks later, you see the healing response, and that was the right move. But the x-ray didn't tell you what to do. Your exam did. Same thing with the older children. You got that 13-year-old obese football lineman comes in and he's complaining his knee is hurting, it's killing him. You examine the patient and you rotate that hip up, and when you flex it, it externally rotates. You get that obligate external rotation. Turns out they have a slip capital femoral epiphysis. It has nothing to do with the knee, but you figure that out by examining them. You don't even need to look at the x-ray. But the x-ray can be normal. What do? We get an MRI and it shows. So exam can give you a whole lot here, and it's silly as orthopedic surgeons we have to say that because we do get some tunnel vision with our x-rays from time to time. But, the same thing goes for these toddlers. You come in, are they curled up in a ball and they won't let you even look at them? That's a different patient from the kid who's on the iPad who's just coming in limping. So you can kind of make that differential oftentimes just by visual inspection. Is this a severe thing? Do we need to be in the ER, or is this an outpatient workup? Get an x-ray, see what's going on. So thank you for bringing that up and hammering it home. All right, it looks like we have a question up here. For an otherwise normally developing toddler, 15-month-old, that doesn't prefer to stand, with no apparent pain or developmental delays, do you simply wait, and how long?
For an otherwise normally developing 15-month-old. So at 15 months, right, just developmentally speaking, like that's a child that I expect to either be walking already or at least being able to stand on your own, but you should be showing some sort of progress towards doing that. So if at 15 months, when the question says doesn't prefer to stand, I'm assuming the kid is also not walking. If the kid is not walking, then is it just a situation where I refer you to physical therapy? Because we live in the milestone world in outpatient. You need to hit your milestone. So if you're not walking at 15 months and you're not standing, when you say you don't prefer to stand, were you standing before? So that changes it. If it's a kid that was standing on their own before, or maybe even taking a few steps, and now they don't want to do that, then I'm worried that something has happened. There's something acute going on. But if they've never stood on their own and they've never walked, then in my head, obviously I'm going to do a full exam. If everything checks out fine and there are no issues, then you may just be developmentally delayed, and walkers that they use to learn how to walk, it's been banned in Canada for years, but it continues to exist in America. A lot of times kids that use walkers early on have the confidence in the walker. Now you get rid of it, and when you're using a walker, you're kind of leaning forward. So they try to walk on their own and they fall on their face. So now the kid has a fear of standing and a fear of walking. So it may just be something that simple that they got introduced to a walker too soon. So typically, if we check everything out and it's all good, I still need you to stand and walk. So a patient like that, I would refer to physical therapy, because you shouldn't prefer to crawl at 18 months or as you get older. So let's get them into therapy to make sure there's no, weak ligaments, or just them needing to get therapy for a few weeks and they start doing those things on their own.
Thank you, Dr. Moses, for a wonderful
Very
talk
much.
and hammering back to basics. We could always use to learn that from you, sir. You guys are truly the masters of so much. The one question I do have for you, just because of where you do a predominance of your practice, when you are suspecting things like Lyme's arthritis, how often now are you testing for other tick-borne illnesses?
Good question. So when there's a lot of these labs have like panels where you can test for everything on the same blood test, so to speak. So when I have a concern for something like that, I usually just click that button, because when they come in, everything else is negative, but the Lyme's is positive. Before these, I think this is actually new for them to have this, the subset of labs, is I would just do the Lyme's. Right, I would just do the Lyme's and it's negative, and then my brain starts going in other paths. But because of all these tick-borne illnesses that are more prevalent now, I think that's why this lab is available, where you can literally just check for 3-4 different things from the same lab script, so to speak. So I just kind of do that now to kind of cover all our bases.
Thank you for that, and thank you for making us better.
Oh, God.
Is Lyme disease going up in your practice? Have you noticed it much more frequently? Because I certainly have.
100%.
Yeah.
It's one of those things that, we have students and NPs that rotate out our office, and we get it like once in a blue moon. And it's like, oh, we'll come see what it looks like. But it's almost like, yep, there's another Lyme's. I'm not sure what to make of it.
Maybe there's a lot more deer out there. I don't know.
Yeah.
I can send you over to my house, because there's at least 2 or 3 in my yard every night.
Thank you.
Thank you.
Right. So let's get on to our next presentation. I know we're running a little bit behind here. Our next presenter is Amit Merchant. He has a topic of sports specialization, topic that's near and dear to my heart. We're going to have some discussions about this for sure. Anyways, Amit is a board-certified pediatric orthopedic surgeon, and he's chief of pediatric orthopedic surgery at Hackensack Meridian School of Medicine, if I recall. And he got his doctorate of osteopathic medicine at Touro University, and did his residency at Peninsula Hospital and LIJ, if I read correctly here, and did his fellowship at Johns Hopkins. Come on down.
So thanks, you guys. Thanks for having me. Dr. Moses, you made me a lot more nervous about my office tomorrow. To all the kids with epididymitis, I'm sorry. So we're going to talk about something a little bit different. It's not so much of your child has this, your child has that. This is something that's going to be progressive. It's been going on for the last 15, 20 years. And it's something we just got to be more mindful of. So we're talking about the impact of sports specialization on children. How is this developing in our youth, adolescent population? Some statistics. we got about 72% of school-aged children, this is all US studies, not worldwide, that are participating in some organized sport. Some is one, some are more than one. That's about 60 million kids in the US that's doing some level of organized sport. It's a growing trend. Every year there's more and more young kids starting, and we're starting to see more kids training year-round. So that's something that we're having an eye-opening experience. More kids are training earlier on. They're training longer durations of times. But it's not all bad. There's good stuff that comes from playing sports, doing exercise. It promotes healthier lifestyle. Healthier lifestyle means you're less likely to have body fat, less obesity. You are more cardiovascular fit. You tend to smoke less cigarettes. This type of lifestyle carries on into adulthood. So you tend to have a more physically active lifestyle. It also helps the parents. Parents of physically active kids also tend to be more physically active. This is just one study from Schneider et al., where they followed parents and children, and they looked at mostly tennis players, ones that were just playing tennis versus ones that were playing tennis among other sports, and they just did a bunch of questions. This is a health-related quality of life questionnaire. And they just found that, yeah, these kids that were playing tennis, the parents were also being more physically active. They were playing tennis or other sports, but they also found that ones that are playing a multitude of sports, parents are doing a multitude of sports as well. So keep the kids active, keeps us active, so we also get a little bit of a healthier lifestyle. Not just physical, there's also psychological benefits. Kids that are involved with sports, they have a better self-image, better self-esteem. They have a chance to make friends, friends on the field or track or basketball court. They get exposed to this social relationship building, get exposed to positive role models. The parents that are physically active, the coaches, the trainers, these are all things that builds the psyche of a child, so they're just better overall. There's reduced risk of depression and suicidal ideation. Just like that previous study I was telling you, parents and child relationship also improves. If you have a good supportive parent, that helps, brings a long-lasting relationship with your kids. School also is good. Our middle school, high school athletes, they tend to have higher GPAs. Higher GPAs leads to a higher graduation rate. Higher graduation rate also tied with missing less days of school. So with sports, we want all kids to be active. From a physical, psychological, and academic level, this is all really good things. But now the trend is to specialize in one sport and become the best at it. The volume of kids specializing is increasing. We're seeing more and more kids do this. What's drawing our eyes is what age are they starting to do this? Is it starting to become younger and younger when these kids are specializing? This is just one study. Brenner et al., they followed these young athletes. They're finding 70% attrition rate by the time they hit 13. So that means someone's hitting 8th grade, 70% of them are stopping. Doesn't mean that they're failing to do it. It's just multiple reasons, but we're seeing that they are not pursuing those same sports from elementary school to middle school. Sorry, middle school to high school. Why are we putting so much emphasis on sports specialization? Why are we trying to look at this more closely? Well, multitude of factors. Sometimes it's the kids that they want to pursue. Their role models are the professional athletes, and they want to follow that. There's also secondary gains. Now we have scholarships, professional contracts, money, all the rich and fame that people see, and it tends to pushing these kids to go into one sport. There's a belief that you do one sport, you practice, and you become perfect at it, and you want to start at an early age because you want the leg up on the next kid that lives down the block. So we have this ideal that we can get them starting out when they're super young, that we can eventually lead to this. The truth is, it just doesn't happen. Only 0.2 to 0.5% of high school athletes actually get professional level. This is one study. So we're trying to figure out who are those kids that are actually getting to the professional level. One is family history. If you have a good role model, someone that's in your immediate family, that's a really big predictor of having sports success. Sports success meaning you are in a positive environment, supporting you, getting you to that career of professionalism. This one study, they followed Division I athletes at one university. They followed these athletes, they did their questionnaires, and they found out that 70% of these athletes, they didn't specialize until later on. So that's 15 years versus 14 years. So they didn't come into high school trying to be one sport and be the best out of it. They actually came into high school with a multitude of sports, and then midway through, they started specializing. So we're seeing that elite athletes are the ones that are specializing later on in their career. So how do we classify this? How do we know who's that sports specialized kid? This is the Jayanthi 3-point scale. These are simple 3-point questions, and they're all yes or no's. So is the kid viewing their primary sport more important than all the other sports? Has this athlete quit everything else just to focus on one sport? And are they training intensively for more than 8 months out of the year? This is 8 continuous months, not so much of play a few months, take a break, play a few months. So it's more than 8 consecutive months. Based on these yes or no's, if you have 1 yes, you're a low risk. 2 yeses is a moderate risk. 3 yeses is a high risk. The 3 yeses are the ones that we are looking the most closely at because we don't want all the negative effects that can come from that. So why are we focused on the 3 yeses? Why do we have to spend so much effort on trying to make these kids specialize later on in life? Well, it all started off with, who are these athletes that are getting hurt all the time? The ones that shows up in our office every 6 weeks of one injury or another. So this was one study that they followed close to 1,200 athletes, roughly middle school and up into high school. They looked at all the injured athletes versus the non-injured. They found that the athletes that were injured more often were the ones that were more highly specialized, the ones that tends to focus all their time on one sport. So there is a huge linear relationship with how much specialization is happening with a child and how often they're becoming injured. And they found that more than 16 hours a week was the biggest risk of developing some injury. So what's the dangers? Well, there's a bunch of things I'll show you in just a few seconds. But we're reducing motor skill development. We have a child that should be able to play a bunch of different sports. We want them to be the jack of all trades. But if you stick them in one sport, they get really good at one sport, but then they lack the neuromuscular control. They lack the cognitive abilities to play in a group sport. But these are things that they just don't develop properly early on. They're more likely to get this overuse injuries, overtraining injuries. They can get psychological burnout. Then they start enjoying less of the sport that they wanted to play. So this is a very simple slide. All you guys got to do is memorize it, and you can do my job for me. But these are things that look at it and think about it. When you have a kid that's coming into the office, hopefully it's not limping, but it's knee pain, shoulder pain, wrist pain. You want to try and figure out. Ask the parents, how's he doing with baseball? Is he a pitcher? Is he shortstop? Is he batter? They say, he's not throwing as hard as he wanted to. Is he sleeping at night? No, he's not sleeping so much. He's going to school, he's always tired, grades are dropping. This is when things start perking up in your ears? Is there signs of overtraining? Is there signs of him specializing too early on? Okay. All is not lost, though. We have really good evidence that specializing too early to try and create these young elite athletes, it's not beneficial. It's actually counterproductive. It's more harmful to these kids. We can't change the culture of where we live. We have clubs and tournaments for every level, for every sport. We can't get rid of all of that. Sports is here to come. We're going to still see lots of injuries, but we got to try and foster this productive environment where we can try and tailor kids around. Maybe do less of one sport, pick up something else in your off season so that we keep them enjoying what they love. This is another busy slide. These are all the different American Academy of Pediatrics, the American Society of Sports Medicine, all of these things. If we just focus on that first row, what's their position on early sports specialization? They all say discouraged. I'm going to point out only one that did not say discouraged. That is the International Olympic Committee. I'm not hating on the Olympics, but they said it's okay in an acceptable environment as long as they're fostered, blah, blah, blah. That is Olympics is a little bit different. They focus on really young elite athletes where they do gymnastics and other sports, and that's where those peak elite levels, they actually topple out at early teenagers. So I'm going to go somewhere between the American Society of Sports Medicine and the International Olympic Committee. I'm going to say don't specialize too early, but if you really enjoy playing a sport, go ahead, play in sport. And I'll give you some pointers on what to look out for. We want to sport diversify. This is sport sampling, sport diversification. We want to expose kids to as much as possible. Let them play a different sport every single season. If they don't want to play any other sports, let them just have freedom to play around. There is a huge benefit for letting kids run around on a playground, play, do whatever they want to do. This is actually on a more biologic level. They're developing the appropriate neuromuscular skills. Climbing up a ladder is very different from climbing down a ladder, climbing on a jungle gym. It's all different things that they need to learn how to do. So allowing unorganized free play is one of the best things we can do. So final recommendations. We really want to not let kids do more than 8 consecutive months of sports. I always try to talk to my young athletes. If you want to play something in one season, nowadays all sports are going 3 or 4 months long at a time. Let them play that out in the off season, pick up something different, play a different sport, or just have the time off. Then you get back to training 3 or 4 months later. Hours of sport per week should be less than their age. That means a 12-year-old shouldn't be doing more than 12 hours per week. That's a very loaded statement. A lot of trainers are going to hate me for that, but it's something where you can intensively train for a certain amount, but let them do something else to help make up for it. If it's just a random pickup game that they still enjoy doing, that is okay. This does cap out at 16 hours, so can't force anyone. We just go based on the data. You're playing more than 16 hours, you do have a higher risk of developing some sort of overuse injury. So we just got to watch you guys much more closely. And then this last slide, everyone can benefit from this integrative neuromuscular training. This is a form of physical therapy. There's many different varieties of it, but a lot of it is just to recruit different muscle groups, have kids be involved with different types of exercises that builds up their muscles, their joints, and protects them. And that's it. Thank you.
sporting academies in the Jersey Shore region are seething in rage right now. You just dropped a neutron bomb on them. Let me drop my own. So, I see, and I'm assuming you do as well, a lot of Little Leaguers elbow. Most pitchers who are in the adolescent population, they tend to pitch on 3 teams pretty much 9 months out of the year. A lot of them go to Florida for their Christmas break to play in tournaments, and then they come back to start their pitching coach throughout January and February. These children tend to have achiness in their medial epicondyle every 3 to 4 months, and they come in to see you and shut them down or try to rest them for a bit, and it goes away. Eventually, though, that growth plate closes, and then 5 years later, they tear their Tommy John's ligament. Do you think there's a link between what we're doing with these children and what is happening in the college and major and minor league ranks, with most major league pitchers having torn their Tommy John's ligament at least once, if not twice? 30 years ago, Nolan Ryan, he pitched for 25 years and didn't tear his until his final season. Something's different. Do you think there's a link?
Absolutely. This is where first is the question of why are these things happening? Why are we seeing UCL tears in a middle school pitcher? Why are we seeing, even in not just with baseball, but why are we seeing ACL tears in a 9-year-old now that's playing soccer or basketball? And it's just the level of intensity that's happening with these kids playing sports. I feel that there is a link. Now we have some data to show. Emory University, who's where this Gianti scale came out, they are at the forefront of following these kids for the longest time, and they're clearly showing that you specialize at such an early age, you are, I don't want to say setting yourself up for failure, but you're making yourself, you're building yourself a very uphill battle with trying to attain that professional level. You want to try and delay that specialization as much as possible.
Let me ask another question here. This is a very topic that's very near and dear to my heart because I see a lot of this. But how do you approach trying to have that discussion with the parents about managing the number of teams you're on at the same time, or perhaps choosing different sports at different times of the year? You've placed some great statistics up there, and I've typically memorized similar numbers that, 0.03% of high school basketball players make it to the NBA, 0.08% of high school football players make it to the NFL, and 0.6% of baseball players in high school make it to the minor leagues. But nobody wants to hear those statistics because their child is different. So how do you try to convince them that perhaps being a multi-sport athlete is more beneficial to them? Have you seen that it's easier to try to convince the parents, the children, or have you just given up and let them do whatever they want?
So there's multiple ways of looking at it. The ones that aren't having any pain, the ones that aren't having any issues, we don't see them in the office. So that's the one downside. We don't have the way of how do we protect those kids, because we just don't see them. They're not showing up in the office. The ones that are showing up, it's because something occurred. They have some sort of injury and we can intervene. One time you see them, you're like, okay, take a break for a few weeks. When you start seeing the same kid showing up in your office every 2 months, it starts to click. And then that's when I have to start laying down the possible long-term prognosis with the parents. And we say that this is something that's physically damaging your child's joints. We take an extended break. We have to miss a few seasons. A few seasons for a kid is a lifetime, but in reality, it's only 10 months. And get them on a guided physical therapy program and see how they do. The one positive is now everyone is so diligent about pitch counts. Everyone is watching how many pitches a child is doing. We need to try and extrapolate that into other sports as well. How many clubs or tournaments is a young soccer athlete doing? So we're a lot more aware, and we're going in the right direction with that.
The pitch count resets for each team they pitch on, no? Well, Maybe not. Okay, we have some web questions here. The first is, in soccer, have you seen an increase in ACL injuries in sports where there are use of cleats as opposed to non-cleated gear? So I can speak anecdotally. There's certainly a high incidence in my teenage girls for ACL tears. That's one of my largest populations. I don't know what your experience is with cleats versus non-cleated sports, though.
I don't know the answer to that. I don't know if it's. I haven't really asked if it's cleats versus non-cleats. One thing I have noticed is what's the field like. The artificial turf has been huge. Huge in a bad way, meaning I see a lot more injuries when there's artificial turf versus natural grass.
The MetLife syndrome. We have another question is, will you recommend pulling kids out of their sport or taking a break during their season when they have an overuse injury? How does that conversation go? You've already kind of touched on that.
Yeah, it is
Tough.
It kind of depends on what the condition is. If it is, my past example, I have a young baseball pitcher. If they're having this medial epicondylitis or medial apophysitis, that is where we place them on roughly 6 weeks of rest. We start some physical therapy to help rehabilitate them. If I'm seeing something more serious where we're seeing, we call it Panner's disease, or we're seeing osteochondritis dissecans, that's a more serious diagnosis where we're affecting vascularity of the bones. Those are ones where we have to say, take a break for an entire season. If you really are serious about pitching, take this season off, recover, and then you can plan to get back in the next season. Missing one season is not going to end your career.
I think,
I just had a quick question. Thanks for that talk. I think it was great. I agree with pretty much everything you said there, and I see all of those same patients. But really from a personal perspective, I just had a question for you. How do I, without single sports specialization, force my 2-year-old to fulfill my dream of playing in the National Hockey League? Any tips?
You can definitely play roller hockey with them in the hallway.
Thank you.
I think we have a final a question here. Is there a sport that you notice more of an effect on the child rather than another? Gymnastics. Oh, sorry. Yes. What do you think?
I probably would agree with you in terms of gymnastics, and that's just the way of how history dictated this. Yeah, in gymnastics, it's an Olympic level sport, obviously, but that tends to focus on these kids practicing and training at a much higher level at a much younger age. An elite level gymnast is going to be 16, 17 years old versus an elite level any other sport is going to be in their mid-20s.
Yeah, the burnout is very high amongst the 8th grade to freshman year sort of population, and it can really be emotionally devastating when the injuries start to add up and they don't have the maturity to deal with that. So it's tough. Dr. Moses.
Yeah, thank you. Great talk. This was really an eye-opener for me and something that I feel like me, I know who else is in primary care here, can actually have a big role because they're coming to you after there is a problem, so having that conversation on a primary care level, because I'm doing sports physicals and sports clearances nonstop. And it's not, even in my family with some of my nephews and nieces, like my sister drives her kids to Virginia for soccer, and then Pennsylvania for soccer, and then there's the school soccer, and I'm talking within the same week. They've traveled overseas for soccer, and the whole less than 0.2%, 0.3%, every parent in their head says, hey, that's somebody's kid that started there. So I think putting an emphasis, some sort of collaborative effort, so to speak, because the goal, is to make business bad for you. Essentially, is we don't want them to come to you, right? Because we want them doing multiple sports and not really specializing at such a young age, So I guess my question for you is, what role do we have to play? And it's definitely something I'm going to add to my repertoire of talking now to some of my to the parents, especially because, like he said, a lot of parents are trying to live vicariously through their children. Because I am not driving my kid here and there. You're going to play at school, and once the season is over, you're done. But I feel like when parents get to that level, it's almost like you're going to do what I wasn't able to do. So I guess my question for you is, what role do you feel like primary care has to play in the pediatric population in terms of maybe getting the word out there?
So it's we definitely cannot stop sports from happening. We can't stop the level of intensity that's going on with the training. All we can do is just make parents more aware. The sports specialized young athletes, the ones in middle school, high school. I have family with young kids where they spend every single weekend driving around for multiple tournaments. I told my wife I'm not going to be that parent. And I don't hate sports, but I can't kill my entire weekend driving my kids around everywhere. But the only thing we can do is make them more aware. I see one kid once every 6 weeks if I'm following them for an injury, or sooner or long or more. It's the parents that are seeing them every single day. And if they really are invested in their kid being the best, they're looking and criticizing every single thing they're doing. But they also need to pick up on these cues. Are they more sleepless? Are they more fatigued? We don't have to stop them from playing sports, but that young athlete, we gotta give them the right resources. Do we need to do some specialized physical therapy, teach them how to pitch properly, improve their neuromuscular balance? We call it proprioceptive or dynamic exercises, so we're preventing knee injuries. We have a lot of data of how we can prevent ACL injuries in young female soccer players. We just got to be more proactive with giving that treatment out.
Kind of just started answering it for me, but how much emphasis do you place on sleep and nutrition with the specialization education?
Sleeping, I'll be honest, I don't do as much with sleeping. I just give the generic statement of make sure you're sleeping at least 8 hours a day. Nutrition, I talk a lot with parents. You can't get everything you need from a simple multivitamin. You can't just take one tablet and say you're good forever. We actually have to discuss fruits and vegetables is actually more important than taking a multivitamin. So I try and go over nutrition as much as I can with them.
All right, thank you very much. Let's
Thank you.
move on to our next topic. So one more presentation before our slight break for the evening. We have Ms. Thea Byrne, who's going to come up and give us a talk on the prevention of secondary orthopedic impairments in children with cerebral palsy. Thea is a board-certified pediatric physical therapist, received her doctorate in physical therapy from Rutgers School of Health, and studied exercise science at the University of Delaware with a minor in disability studies. So please come up and give us a talk.
Hi, everyone. Thank you again, and what an honor to share a stage with such an amazing group of clinicians, many of whom I've gotten to collaborate with at Jersey Shore. So thank you again for this opportunity. As he was saying, my name is Thea. I am a board-certified clinical specialist in pediatric physical therapy. And today I'm presenting on the prevention of secondary orthopedic impairments in children with cerebral palsy. My goals today are simple. Providers will be able to identify preventable secondary impairments, list complex rehab technology that may be beneficial, and demonstrate understanding on the importance of early detection and treatment. I have nothing to disclose, and I have no financial incentives regarding the equipments referenced in this presentation. So we're all familiar with cerebral palsy. Whether you are a physician working in orthopedics, a rehab provider, a nurse in the PICU, odds are you've come across a child with cerebral palsy in your practice. Cerebral palsy is an umbrella term. It describes a group of permanent disorders that affect the development of movement and posture attributed to non-progressive disturbances that occur during the development of the fetus or the infant brain. Every hour, a baby is born with cerebral palsy. Cerebral palsy is a very heterogeneous disorder with several different motor types, with spastic cerebral palsy being the most common. The average age of diagnosis for cerebral palsy is 18.9 months of age. This is an important detail as we consider the prevention of secondary impairments. So first, I want to talk about primary impairments. A primary impairment is present at the start of a diagnosis. It is a key feature to the diagnosis. When thinking of CP, we most often think of abnormal tone and spasticity. However, this can be very hard to classify early on. We want to know that tone is found to increase up to the age of 4. So in infancy, it may not always be known whether the tone is abnormal or not. Another common impairment is reduced postural control. What does this mean? This is the ability to maintain upright alignment even when forced outside of our limits of stability. Reduced selective voluntary motor control. This is a big term. It describes the ability to isolate specific muscle groups while stabilizing other muscle groups. This can also contribute to impaired reciprocal inhibition or the isolation between sides of the body. As you can see in the graphic here, impaired sensory processing, which is another primary impairment, can cause a developmental disregard that disrupts the process for learning new movements and the ability to experience a variety of movements. This is kind of an intro to some of the other things we're going to discuss. A secondary impairment are impairments that develop over time as a result of the primary impairments. This includes muscle hypoextensibility, joint contracture, skeletal malalignment, impaired force production, decreased strength, and impaired endurance. My challenge today is to help us see how we can prevent these orthopedic impairments if we act early on. So common orthopedic impairments with cerebral palsy, hip dysplasia is one of the most common, with the prevalence of hip dysplasia occurring in about 30% of all children with cerebral palsy and about 90% of all non-ambulant CP. It is recommended that routine hip surveillance starts around the age of 2. Osteosarcopenia, or low bone density, as well as low muscle mass, significantly decreased bone density is virtually universal in non-ambulant children with moderate to severe CP after the age of 10. Torsional deformities, such as the picture here, where we have tibial torsion and femoral anteversion, scoliosis, varus foot deformities, and limb length discrepancies are also common. For the purpose of my presentation today, I'm choosing to focus on the birth through 3 population. This is because we are in a critical time period where neuroplasticity is at its highest rate. This is the child's nervous system's ability to reorganize synaptic connections for learning and in response to injury. This is that use it or lose it principle that we remember learning about in school. For cerebral palsy, the musculoskeletal system and neurological systems are very much intertwined for development. This is also the period of time when bones are most susceptible to change. We know through Wolff's Law and the Kueter-Volkmann principle that bones grow through activity, variable pull on muscle attachment sites, as well as weight bearing. And together, when those things are impaired, that's going to cause secondary impairments. So first, I want to go back to the anatomy and physiology behind cerebral palsy. When I first learned this, it really hit home to me on why it's so important that we intervene with these children as early as possible. So hang in there with me. The first slide is a review, and then the next slide is where it really stands out. As we know, cerebral palsy is a neurological developmental condition. Just like how neuroplasticity occurs in adults post-stroke, this same process of neurological rewiring is present in infants with cerebral palsy. The cortical spinal tract is our pathway for motor skills. At birth, children with IPS present with ipsilateral pathways as well as contralateral pathways coming from either side of the brain. Over time with practice, these ipsilateral pathways become pruned. This is called synaptic elimination, and it is a period that occurs from 18 weeks gestational age to several months post-term until each neuromuscular junction is innervated by just one axon. This process creates the beautiful contralateral pathways that we're all familiar with. Now, for atypical neurological development of the corticospinal tract, we're going to use the example of having a right-sided hemisphere injury. Initially, the peripheral pathways are the same. You have ipsilateral as well as contralateral pathways present. Over time, pathways coming from the right hemisphere get less practice and thus become selectively pruned. In this case, the left hemisphere gets all the practice. This strengthens both the ipsilateral and contralateral pathways coming from the left side of the brain. This selective pruning begins at 2 to 3 months after birth, which is why it is so important to act early and work to rewire these pathways as soon as possible. This is why it is critical to detect cerebral palsy before 6 months of age. After 6 months of age, we have reinforced abnormal neurological circuitry. Now the left hemisphere is acting for both the right and left side. This is an example of why we see association reactions in an individual with hemiplegic CP. So for our kids with hemiplegic CP who try and climb a ladder, when they try and open the ipsilateral or one hand, the other hand opens as well. That's what we see. Makes climbing a ladder really hard. As you can see in the graphic displayed, there is a cycle of disuse that starts in the brain that affects muscle stimulus for hypertrophy, muscle size, as well as muscle quality. Why is this important? Around 12 to 15 months of age, muscle volumes of children with CP appear separate from those of typically developing children. This is related to altered, reduced biomechanical loading of muscle. We know that muscles in children with CP are reduced in volume up to 40%. Their muscles are shorter in length, have longer tendons, and fewer sarcomeres. We know that from a neurological perspective that intervening before 6 months of age is critical, but intervening before 12 months may be even more crucial for maintaining muscle volume. Experts now consider the silent period, or that period of time where children are not expected to be rolling or sitting yet, to be outdated because cerebral palsy or the high risk of cerebral palsy can be accurately predicted before 6 months of corrected age with evidence-based tests and measures. So why do we want to detect cerebral palsy early? We want to maximize neuroplasticity and access rehab during this critical time window. We also want to be utilizing CP-specific interventions and not just interventions for general motor delay. We want to minimize secondary impairments as we have discussed. We also know that with intervention under the age of 2, the gross motor functional classification system can improve by 1 level. And lastly, we want to empower parents. 86% of parents of a child with CP suspect it before a clinical diagnosis is given. A prolonged diagnostic process is associated with lasting anger and parental depression. I have one parent who has shared some videos and photos for this presentation, and she asked me to share on her daughter's behalf. She wishes she had started sooner, and she hopes that in me sharing her daughter's images will help other children start the process to start therapy sooner. Children with CP reach 90% of their gross motor potential by the age of 5, with most achieving this at age of 3. This is why it's critical to intervene early with evidence-informed interventions from a neurological, developmental, and musculoskeletal perspective. You can see here a list of multiple risk factors for cerebral palsy. Half of all infants with cerebral palsy will have some of these identifiable risk factors, where the other half, pregnancy and labor, may have appeared uneventful. It is thought that 14% of CP cases may have a genetic component. I want to zoom in on hypoxic ischemic encephalopathy. This is when blood flow or oxygen is limited at birth, potentially causing a brain injury. Therapeutic hypothermia is the process in which the baby's body is brought down in temperature, either through a cooling cap or a blanket, to allow the brain cells to recover and prevent the spread or severity of brain damage. For children with HIE, therapeutic hypothermia does not negate the risk of CP. It improves the survival rate and reduces the chance of severe disability. A follow-up study was done on children with and without cooling intervention, where they looked at these children at 6 to 7 years of age. For children with HIE who did not receive cooling, 36% were diagnosed with CP. For children who did receive cooling, 21% were diagnosed with CP. This changed the prevalence from 1 in 3 to 1 in 5, which is amazing, but we do have to remember initially all of these children are at risk and need to be thoroughly screened. So I know this is a busy slide, but hang in there with me. First, I would like to point out the algorithm. on the left of the slide. This is now regarded as the international guidelines for early CP detection. For children under 5 months corrected age, the tools with the best predictive validity include neonatal MRI with 86 to 89% sensitivity, Prechtel's general movements assessment with 98% sensitivity. This is a test that is performed through video assessment, and the videos are performed with the child laying on supine on a blank sheet, and then they're taken over several weeks throughout their development under the age of 4 months. The Hammersmith Infant Neurological Exam, which you'll hear me refer to as the HINE, is 90% sensitive. This can be performed from 3 months to the age of 2. This is a neurological test and battery that gives you a total score and tells you how concerned you need to be. High quality evidence indicates that a trajectory of abnormal general movements, or HINE score, with an abnormal MRI is more accurate than individual clinical assessments in isolation. There's also evidence that CP can now be accurately diagnosed at 3 months of age with a HINE, a GMA, as well as neuroimaging. So some of the best practice guidelines for treatment of cerebral palsy under the age of 2. The top recommended interventions for infants and toddlers at risk of cerebral palsy include immediate referral and initiation of CP-specific interventions that are both playful but targeted, with an additional focus on improving parental capacity through a parent coaching model. I'd like to draw your attention to the big blue box, in which we will focus on motor skill development. There's a strong level evidence on task-specific motor training, with passive intervention strongly not recommended. For children with unilateral CP, there is strong evidence in support of early constraint-induced movement therapy or bimanual therapy. For complication prevention specific to the musculoskeletal system, supported standing programs have promising results for increasing bone mineral density. Expert consensus states that this should be initiated before the age of 2 for prevention and should be used among or alongside of other interventions. For risk of ankle contractures, AFOs may be beneficial to maintain range of motion and allow the development of standing for non-weight-bearing individuals. Consideration should be taken as they limit ankle movements, which can also be contraindicated. For prevention and pain and tone, spasticity management and a comprehensive management model is recommended. Hypertonicity can cause contracture, deformity, muscle stiffness, and abnormal motor control. There is limited evidence for Botox, with the effect on developing muscle being unknown. A conservative approach is recommended. For this age range, sleep systems are not recommended due to the risk of reflux, breathing difficulties, and death. However, use of Botox or baclofen can reduce pain and improve sleep. Additional recommendations for children with excessive movement or easily elicited reflexes is safe swaddling with the hips positioned in abduction and flexion to prevent the additional risk of hip dysplasia. Anticipating secondary impairments enables timely access to intervention, which requires intentional communication among professionals. This is always an interdisciplinary approach. We want to ask ourselves some key questions. Are they non-weight bearing? Are they at risk of hip dysplasia? If so, we might be thinking about getting them a stander or looking into referring them to physiatry or orthopedics for some hip surveillance. Are they at risk of osteosarcopenia? Is this child likely going to be non-weight bearing? If we use the HINE score and we know that that's less than 40, they might not be ambulatory. So we know that children with limited ambulation, history of feeding problems, use of anticonvulsives, previous fracture histories are at risk for future fractures. For this, interventions to increase weight bearing, physical activity, and the use of biphosphonates is recommended. Do they have abnormal muscle tone or reduced selective control of the lower extremities, and are they at risk for ankle foot contracture or deformity? If so, we're referring to our orthotists and prosthetists for ankle foot orthoses. Supported standing devices are an intervention that is recommended for prevention of secondary impairments. The strongest body of evidence supports that standing for maintenance of bone mineral density as well as range of motion. There are several different types of standers. There's the supine stander, which you can see all the way to the right. In the middle is a prone mobile stander, and on the left is a sit-to-stand stander, to name just a few options. These are recommended as part of a 24-hour activity guide to reduce sedentary behavior. In addition to maintaining bone mineral density and maintaining lower extremity range of motion, supported standing devices reduce pain, improve gross motor function, increase participation in standing transfers, and there's qualitative data that they may also improve bowel function. Lastly, this is an endurance intervention. It is not passive for the children with non-ambulant CP. It increases their heart rate as well as increases their energy expenditure. How does this make a difference for families? They may not need to stretch them more. Eventually, as their child gets bigger, they may not need as much assistance for lifting. And we also know that this population is at risk of secondary cardiovascular impairments. This is an intervention we can provide them early on to work on their aerobic capacity, even if active movement is limited. Standing is a dose-dependent intervention. I'm dosing standing based on my goals. So if my goal is to maintain lower extremity range of motion, I'm shooting for 45 to 60 minutes a day. If I want to maintain bone mineral density, I'm shooting for 60 to 90 minutes a day. And if I'm looking to improve hip stability or hip health, I'm looking at 60 to 90 minutes a day in a position of hip abduction, just like the standard at the top image. And then we also know that 30 to 45 minutes a day causes a short-term decrease in spasticity. Supported stepping devices are another option on the market. Together, standers and supported stepping devices facilitate opportunities for biomechanical loading, potentially helping to build and maintain muscle and bone integrity while promoting physical development. The language is moving away from calling these gait trainers due to issues with insurance coverage and the fact that they're still valuable when the child is non-ambulatory. This is an example of two common supported stepping devices. On my right is the KidWalk, and on my left is the Riften Pacer. There is evidence that supported stepping devices improve bone health, transfer participation, head and trunk control, physical fitness, and supported stepping devices may be more effective at improving indoor exploration than self-propulsion of a wheelchair. Hands-free devices also improve upper extremity use for self-feeding and play. And so this is a video of a friend of mine who loves her supported stepping device. This is the KidWalk. As you can see, she starts walking, and you'll see mom will walk by in just a moment. So this child, we actually have to hide the supportive stepping device if we want to work on any other skills, because she just loves it so much. And as you can see here, she gets herself stuck, and then she uses her hand. Come on. There we go. And she gets herself unstuck. So this is a visual that was published as part of a case study by Paling and Livingstone in 2023 for twins under the age of 2 who are classified as GMFCS level 5 with on-time use of adapted equipment. We know that GMFCS level 4 and 5 make up 1/4 to 1/3 of all CP cases and are more likely to experience secondary impairments. The first step in providing on-time equipment is providing an accurate motor performance prognosis, either through a Hammersmith Infant Neurological Exam score below 40 or a GMA motor optimality score below 8. And you want to perform this prognosis between 3 to 5 months of age. When these tools are underutilized, we run the risk of delayed referrals for adapted technology. On-time use of supported stepping devices and standing devices is 9 to 15 months of age, where on-time referral for power mobility is 12 months of age. 24-hour postural management is another emerging area in the research and is more commonly performed in Europe. This is the utilization of a range of interventions to reduce postural asymmetry, improve function, and includes all lying, sitting, standing positions that occur within a 24-hour period. It's a range of techniques to preserve body shape, prevent secondary complications, promote symmetry, enhance function, and improve participation. And this is intended for all individuals of all ages with complex multiple disabilities who are unable to transfer their weight, reposition themselves, or move outside of their base of support and back in without assistance. We know that body forces are susceptible to deformation with gravity and repetitive postures. And while we don't recommend sleep positioners for the very young infants or children under 2, there is evidence that symmetrical supine lying can aid in the balanced function of muscles as the body is more receptive to positioning when the tone is relaxed. So how can this be of use when the child is awake? You can see in the picture here how this child is at risk for a fixed windswept hip deformity. The research right now is qualitative, but I do see it as a valuable intervention for our GMFCS level 5 kiddos, and I'm hoping to see this research further. There are qualitative reports of reduction of postural deformities, pressure ulcers, improved pain, breathing, digestion, interaction, swallow, as well as quality of life. It'll be interesting to see how young children who grow up with this develop orthopedically. A variety of adapted technology can prevent secondary impairments orthopedically, but there are so many more benefits of adapted technology outside of just orthopedics. For example, the impact on upright posture for visual development, social development, language development, and spatial awareness. While the medical model is the foundation of what we do, we know that health is much more than that. The World Health Organization's ICF framework is typically used to guide our practice. Currently, there's a shift in language to be more child and family friendly. This is called the F words. Did your eyes just bulge out of your head? These F words are fitness, function, friends, family, fun, and future, with the goal to help providers focus on factors most important to their children, their current accomplishments, and finding joy in the moment. There are qualitative studies on supported stepping devices reporting increased happiness, autonomy, self-efficacy, self-esteem, and sense of equality. There are also reports of increased engagement in typical childhood experiences, with children in stepping devices being naughty, sneaking up on others, and running away. This is certainly something we see in the clinic. To me, this is true healthcare. It's about improving quality of life and not just muscles and bones. So, general recommendations for rehab, we first want to use a family-centered approach in which the family sets functional goals and plays a critical role in the decision-making team. If the family's not comfortable setting the goals, either due to cultural preferences or limited understanding of the child's functional potential, it's the provider's job to guide them, but not set the goals for them. The approach should be goal-oriented, in which goals are functional, achievable, measurable, and well-defined. Providers should assess for limiting factors that are impeding the child's ability to meet the goals. How is their postural control? Is there a lack of symmetry? How is their ability to isolate movements at specific joints? Are they weak? Then intervention should be targeted to meet the family's needs. Intervention should be enjoyable and motivating for the child to optimize learning and neuroplasticity. If the child is distressed, intervention should stop and the child should be comforted and modification should be provided. This is something we also have to teach our parents, as we know from our early sports specialization lecture. A high enough dosage is needed to meet goals, with the recommended threshold dose of 15 to 25 hours of goal practice for upper limb goals and a threshold dose of 40 hours for appropriately selected generalized motor goals. Well, this is not a hard and fast rule depending on the goal. This is to typically show that we cannot meet the threshold dose in the clinic. How do we fix this? This is where parent-delivered intervention is key through a parent coaching model with regular check-ins, home program progressions, and dedicated time for instruction, education, and opportunities for practice. How does the family achieve this? We have to teach them how to embed the home program as part of their daily routine that they are currently doing. For example, the little girl in the image that I showed you below in the walker, what mom does every time she dresses her in supine, she rolls her to her side and has her use her right arm to assist in sitting up. At the motor training course I attended through the CP Foundation, they recommend 30 minutes a day for infants under 6 months of age and 30 to 45 minutes a day for children older than 6 months of age, for a total of 10 weeks per goal. Some of my parents are preferring to have 30 minutes of purposeful play a day with their child rather than embedding this into their routine. And while we don't want to overwhelm our families, there is evidence that underdosed interventions are potentially ineffective. Practice in the home and natural environment is more effective than in the isolated clinical environment. So families need to be coached, they need to be educated and empowered that they are capable. So there is strong evidence in support of constraint-induced movement therapy under the age of 2. This is appropriate if the child is unable to use one hand as the helper hand and able to tolerate a restraint, with softer restraints like the one in this image preferred. Lower doses are recommended with infant CIMT to safeguard the development of the dominant hand, with caregiver training models being shown as feasible and effective when provided with activities that are just the right challenge. It is not enough to simply wear the restraint. You also have to have activities to perform with the child when it is worn. Bimanual therapy involves activities, games, environmental setup to promote spontaneous use of both hands without verbal or physical prompting. Both CIMT and bimanual therapies should involve whole task training rather than working on part of task. Generally speaking, research supports whole task training when possible to being preferable over part task training. Task-oriented training is recommended with the primary focus on self-initiated active movements and the encouragement of self-direct discovery of the child's environment. Passive interventions such as NDT are not recommended in the literature. This is a forest plot that was published by Iona Novak's systematic review on the current available literature for the treatment of cerebral palsy in 2019. It is casually referred to as the traffic light system, in which green light interventions at the top indicate interventions that we should definitely perform. Above the dotted line, or the worth it line, yellow light interventions clinicians should probably perform, with the interventions higher up indicating that they have higher levels of support. And red light interventions indicate interventions that are not recommended. The size of the bubble in this image is the amount of evidence available. So this is what physical therapy may look like initially for a very young infant who is at risk of cerebral palsy. It may start with a variety of positions for play to enhance motor symmetry, allow for symmetrical weight bearing, and in order to reduce secondary impairments. We all know the benefits of tummy time. There is evidence performing tummy time at least 3 times a day improves child's gross motor skills on the Alberta Infant Motor Scale. Sideline play is another highly beneficial position for allowing gravity-assisted reaching, kicking, gravity-assisted midline play, and strengthening of lateral head control, as well as core and hip co-contraction to maintain this posture and later work on rolling positions. This position is underutilized for play but can be highly beneficial when performed on the right and left side. Supported sitting is another great option that allows the infant to work on head control and head movements with less work against gravity. And supported standing for short periods of time can be initiated as the infant or the newborn can accept 20 to 30% of their weight. This is then taught to the parent to be performed at home. These activities increase the muscle activity, the variety of muscle pull, and allow weight bearing throughout different extremities to prevent secondary impairments while maximizing neuroplasticity. Supine play is also critical. This was seen in Barbara Sargent's work and is an example of task-specific learning to treat a primary impairment in infants at risk for cerebral palsy. Isolation of hip flexion with knee extension is required for normal gait mechanics. At 3 months of age, typically developing infants can perform the skill to kick upwards towards the mobile, like the baby in this picture. What we typically see in our infants with cerebral palsy is either downwards kicking or asymmetrical kicking, where just one leg kicks. For at-risk infants between 3.5 to 4.5 months of age, Barbara Sargent found that 8 to 10 minutes a day, 5 days a week for 6 weeks improved the child's ability to isolate hip flexion with knee extension. So when a family self-identifies a goal of walking for a very, very young child with CP, this is a great home programming activity to perform for pre-walking skills. Here are some treatment ideas and progressions for the older infant at risk of cerebral palsy. So this child presented to me with a positive birth history and a diagnosis of abnormal tone. He started physical therapy at 6 months of age, and his parents' primary concern was that he would always lock his legs in extension. He presents to PT with left lower extremity spasticity, weak left-sided kicking, reduced lower extremity dissociation, scissoring and ventral suspension, left-sided retained ATNR. He was seen weekly with me for 30 minutes and then progressed to an every other week frequency until he started walking, which we started seeing some other impairments coming up, and then we went back to weekly for a period of time. The pictures on this slide show how I got him to weight bear on his left arm and shift his weight over to the left side. Here are some activities we used to work on selective motor control. We progressed from reciprocal supine kicking to kicking in supported standing. This is a reminder that when you teach a family something, to also have them show you exactly what they're doing. Because this is an example of something I wanted, but I didn't want it exactly like this. So we want to work on upwards kicking, not necessarily downwards kicking. So when the family brought this video in, I was able to kind of show them maybe we can reposition the piano a little bit, maybe we can back him up and he can kick towards the mobile above his head, so I can get a little bit more of the skills that I want. And this is him. He does not yet walk in this video, but working on supported standing kicking. And if the ball cooperates, then he'll eventually kick with his left leg. And the last video is Dad trying to teach him how to use hip flexion and core engagement while weight bearing instead of using his whole body extension, right? So this is important because one of the family's goals was to reduce the lower extremity stiffness in the legs. So we had to teach him how to bend. And so what we do is we put his arms out on the toy. He gets the toy when he maintains weight bearing with knee flexion, which is really hard for him, but it got easier. So this is an infant who started with me at 40 weeks gestational age. He was born at 37 weeks and 3 days with mild HIE. His APGAR scores were 2, 5, and 6, in which therapeutic hypothermia was performed in the NICU shortly after birth. In addition to this, he had meconium staining, right-sided shoulder dysplasia, as well as a positive conception history. He had a normal MRI in the NICU. At the time of initial evaluation, he presented with asymmetries, including a right-sided head tilt and turning preference, visual tracking asymmetry, asymmetrical kicking, right-sided hand fisting with reduced right upper extremity movements. Throughout the course of physical therapy episode, he presented with abnormal general movement trajectory and a trajectory of abnormal hind scores. And this is a general movements video in which we then grade the quality of movement. So very similar to how you might look at a hemiplegic gait pattern versus a crouch gait pattern. There are different qualitative patterns of movement for infants that you are looking for through the Prechtel's general movements assessment. So he received physical therapy on an every other week basis with a focus on caregiver training. In addition to this, he had a short-term course of constraint-induced movement therapy through the CP Foundation in Atlanta, in which he was coached by an OT over teletherapy in how to provide the services. His family is highly involved and excellent in carrying over his home program. We started the activities I discussed on the first slide, and then the remainder of the session continued to promote symmetry as he developed. He's been seen with me on an every other week basis. So this is him now standing through his left leg, and this is him standing through his right leg. Yay. And this is him now reaching with his right arm. If I can get it to go. There we go. And the left arm comes to join it, and he loses the grasp. But then he gets his right arm out again. Well, this is an example of a milder case of a child who's at risk of cerebral palsy. We know that even more mild cases are at risk of secondary impairments, including hip dysplasia, pain, and contracture. At this time, this child does not have a diagnosis. His family reports really enjoying and seeing an impact on the proactive, preventative approach. This is an example of a fantastic outcome, but we know that cerebral palsy is very heterogeneous. We know that this outcome is not going to be possible for every child for a number of different reasons. It's my hope that the next time you work with a child who is at risk of cerebral palsy, you will feel inspired to help the family initiate services in a proactive manner to the benefit of their orthopedic and neurological systems. Thank you so much for your time today. This has been an incredible opportunity. Special thank you to Dr. Haynes, Jen Palmer, and the entire team behind the scenes. I would now like to open the floor for further discussion and questions. With Dr. Haynes, of course, and Dr. Collins.
Wow. That was an awesome talk. I have two questions for you. First, a statement. So I think this is my favorite population to deal with because you don't treat just a patient, you treat a family. And you are truly the epitome of that. Your passion here is palpable. So I hope that is commended and fostered in your department for sure. First thing I would ask is, do you ever use any type of gait analysis, surface EMGs, anything along those lines? And if not, would you be willing to start a program here?
Ooh, I like that question. My manager's sitting here, as is the director of rehab. So we are not currently using anything, but we are certainly open to more opportunities for growth.
Gotcha. Boy, I hope that's a huge hint wherever they are. I got to tell you, 'cause it's something we could use. There's no place in New Jersey that does that. You either send someone to HSS, maybe down to DuPont if you're lucky. Trying to get in, they don't take all insurances, so it would be a huge benefit here, and you seem to be the perfect person.
Yeah, access to therapy
Absolutely.
for these patients is very difficult. Yeah, especially in this area, we have limited, options. Further up north, there's, you got the city, and there's a lot more, but there's only a few facilities here that will do neuromuscular therapy for children with these issues.
Absolutely, I do see that there is a shortage in this area, and it's definitely a need that I'd love to fill. So,
Just one other question, and I'll be quiet and pass it off to Dr. Collins and everybody else. When it comes to assistive devices, we have a lot of difficulty getting a lot of these things approved. The verbiage that you use with insurance companies, you know it better than we do. So are there resources that we can use to assist us in getting some of these things, whether it's an A-frame, sit-to-stand, whatever it is? Can you help us with that?
my recommendations would be to have a really good ATP or adapted technology professional. I think when you have someone who is really skilled and really just the expert on equipment and only equipment, it can really help you. They will make sure that things are ordered correctly and properly. And my preference is to have a physical therapist who knows the child and the family very well, because I find that when you work in a more collaborative model, you are able to order things with much more precision and accuracy. And then also being very good at writing a letter of medical necessity is crucial. Lengthy letter of medical necessity often is crucial. Every nut and bolt probably needs to be justified.
We have a question in the audience. Amit.
So I have plenty of kids that are in the earlier intervention therapy program, but a lot of parents are trying to ask, what else can I do? And so I guess the question is, if I prescribe additional physical therapy where their parents are willing to go for more outpatient, is that helping? Is it quantity over quality, or is it making a difference doing more therapy?
It's a great question. Sometimes, as you know, we talked about the threshold dose, so more therapy is not always a bad thing for these children, but we do want high quality therapy too. So we want to make sure we're using evidence-based, tests or evidence-based interventions. And then the other thing is the quantity really needs to be performed at home. So you need to make sure that the family's using their time in therapy to also learn a lot of skills to be performing with their child throughout the day-to-day. Great question.
So that was a wonderful talk, and as a child neurologist, I'm obviously very interested in the idea of neuroplasticity. I found it very interesting when you talked about the need for early intervention. Early for you was actually earlier than I thought about for myself. You're talking about before 3 months. So I'd love to get your thoughts on what a model like that would look like when infants are being discharged from the NICU. Because when they're being discharged from the NICU, at least at Jersey Shore, we refer to our wonderful ITAP program, which assesses them in 2 or 3 months. Maybe Dr. Marcantona can correct me. And then maybe they're sent to therapies. Families will call earlier intervention a couple months. So I feel like therapies aren't getting started for a couple of months, potentially missing that critical window they were referring to. So what do you think we could be doing better from, discharge, parental training, or referrals to therapies?
I think definitely more referrals to therapy is key. Dr. Marcantono, our physiatrist who runs our infant toddler assessment program, has been certainly sending me more and more young babies. I have quite a bit of itty bitties, as I like to call them. But we have a couple of really little babies who are starting with me at 2-3 months of age. And I have 2 children who started with me right after discharge from the NICU, because our NICU team is just really fantastic at identifying this as well.
Moses.
Just to add to what Thea was talking about, at her very passionate request for getting these children in, we're actually working on slightly changing how we do our NICU follow-up program. So we are trying to get these children in kind of right after the NICU, maybe around 2 months corrected age, to physical therapy to get their gross motor assessment started and done. And if they come back high risk, make sure we're getting those therapies started sooner, because right now we're not seeing those kids for follow-up until they're closer to 4 months corrected for the most part. So Thea and I have been working really closely to identify which children to refer early on to get these assessments done. So we're in the process of hopefully getting that actually started very soon. Correct, with the NICU. Yeah, we can talk too a little bit more.
Definitely. That was a great way to summarize that as well.
So I have 2 questions that are totally separate. The first one is the role of aquatic therapy, aqua therapy for CP. It's something, I have one patient that does it, but it's not very popular. I don't know if I guess just for you to talk about that a little bit. The second thing is the AAP, I think, American Academy of Pediatrics, maybe 2 years ago, updated their developmental milestone guidelines, which I am yet to subscribe to. But something, an example is normally you should be walking by 15 months. But now they're like, well, 1 to 2 steps by 18 months. So it's almost like things were pushed back further and I feel like doing that is going to be counter to your point in terms of the earlier the better, because I'm not referring until I see a delay, and with the premature babies, having a program, because they're going to come out delayed. So having a program from the NICU helps, but for those kids that are born full term, and as soon as I see you not meeting your developmental milestones, I'm sending you. But now that those milestones have been changed, I'm like, what, do I wait an extra 2 or 3 months because of this updated guidelines, which I, again, not subscribing to yet, and how does that affect, again, what you guys are trying to do? And great talk, by the way.
Thank you. So twofold question. I think the updated guidelines that were put out by the CDC, that's the ones you're discussing, correct? Those are really to identify autism. So you want to remember that different milestones are for different reasons, right? And so if you're looking to identify autism, those are the milestones to look at. In terms of referring, if you ever have a doubt, you can refer to physical therapy. Typically, my coworker and I know we say it all the time, we love a one and done. If you don't need therapy, we don't want to see you in the clinic. We want you to go out and enjoy your life. To answer your question on hydrotherapy or aquatic therapy, I think that, going back to the presentation, things have to be really task specific. So if we want to be walking, we typically need to work on walking. As we get older, could aquatic therapy be a little bit better? Absolutely. There's a lot of benefits to warm water environment. That's going to reduce tone and spasticity. It's going to reduce the weight bearing on the limbs, right, with the buoyancy. There can be benefits, but you also want to make sure task specific, exercises are also being performed.
We have a few web questions. First is any research on Firefly Up-C mobility harness?
So yeah, this is interesting. I've seen this before. A parent wears it and the child kind of goes into it. It's something that I actually, for a hot moment, was like to management, hey, have you seen this? What do you think about ordering something like this? Before we got our own kid walk. So I don't know of any research out on this. I have not personally been able to use it yet.
The next question is, do you see that parents have a stigma about getting equipment for home and would rather get their child's adaptive equipment either through therapy or through the school where they potentially have therapy programs?
There's definitely a stigma and an internalized ableism when it comes to certain types of equipment. I definitely think that families are not always ready to start this process, and that can be a big challenge. I do find that having something in the clinic to show them makes them realize, oh wow, my child has potential to wheel themselves around in a wheelchair. That's a big deal. To have the child in a walker and see their child walking for the first time when they didn't know if that was a goal, that's a big deal. So I do find that having something to trial in the clinic does help them.
We have another comment from, looks like Jill Stevenson, the OT supervisor up at JFK, saying that they constantly run into barriers of very long wait lists for appointments for the babies and need specialists in physiatry as well as in pediatric neurology. Is there any suggestions on how to get into these and to be able to get the babies access to these? It kind of goes back to, do we have enough of programs to cover all of these children? And the answer, unfortunately, is probably not as much as we should.
I think it depends on how you're managing your wait lists, right? If you have a system to manage the wait list where you know who the highest priority children are, you can manage it a little bit better versus the lower priority children where, maybe we're working on constraint-induced movement therapy over handwriting. It's unfortunate, but yeah, we do have some limitations.
Perfect. Yeah. Anyone else? Well, let's take a little refreshment break.
Right.
Yeah.
Thank you.
So we have a few more here to go. Thank you guys who came back. Our next presenter here is Nicole Marcantuono. She is going to give us a talk here on, I believe, amplified musculoskeletal pain syndrome. Nicole is board certified in physical medicine and rehabilitation, and she's the section chief of Pediatric, PM&R at Jersey Shore. She attended Drexel for medical school, and I think you did your residency at Thomas Jefferson. Is that right? Well, Nicole, come up and let us know all about amplified musculoskeletal pain.
All right, good evening, everybody. Thanks for sticking around. I'm sure a lot of you have seen patients like this before who come in and have an injury that heals and gets better, but they're still complaining of pain. So what do we do when something like that pops up? So this is something that I see very often. We're very lucky here. We have two of our physical therapists who also treat children with AMPS here. So hopefully we'll get a good talk going forward. I do not have any disclosures to make. I apologize. I think I forgot to put my objective slide in here, but hopefully we are going to be walking away today with a bit better of an understanding of amplified pain, when to refer to us for treatment, as well as how we treat this condition. So chronic pain in pediatrics is actually more widespread than I originally thought before going into this field. So chronic pain affects anywhere from about 10 to 40% of children and adolescents throughout their lifetime, with approximately like 5 to 10% of these children experiencing severe debilitating pain. So as most of you know, we tend to define chronic pain as pain that is lasting longer than 3 months duration. However, it can also be pain that's lasting longer than the expected healing from an injury. Most common types of chronic pain that we see are headaches, abdominal pain, and musculoskeletal pain. And the pain tends to increase with increasing age. So it's less common to see chronic pain in, a 7-year-old than seeing it in a 14-year-old. We do tend to see it more in girls than boys, but certainly we do see it in both. And one of the reasons that speaking about chronic pain is important is back in 2014, I apologize for not having a more updated number, but the estimated healthcare costs associated with pediatric chronic pain was almost $20 billion. So it's really important that we get these kids managed, keeping them out of the emergency rooms and inpatient hospital stays for $1 million workups when it's clear that we're dealing with amplified pain. So before we continue, we'll just talk about the definition of pain. So pain is an unpleasant sensory and emotional experience, primarily associated with tissue damage or described in terms of such damage. So we'll talk a little bit later on about how pain can be extremely subjective and individual dependent as well. This slide is just a kind of basic schematic of what we would classify as the pain pathway. We're not going to go into significant detail here, but really I just want to demonstrate that the nociceptive experience begins way down in those nerve endings when the A delta and C fibers get stimulated, and those sensory afferents send their signals through the spinal cord and the ascending neural pathways up into the thalamus and then on to the sensory cortex. So it's really not until these signals reach that sensory cortex that we experience them as pain. This slide also kind of demonstrates here on your left-hand side the various receptors that we can kind of target for treatment of pain if we are using various medications. Chronic pain is not just a medical issue. We tend to talk about pain utilizing a biopsychosocial model. So pain impacts many areas of a patient's life. In children and adolescents, it certainly impedes school attendance and performance. It tends to isolate children and adolescents from their peers and their family, can cause higher rates of depression and anxiety, impair sleep, and then particularly in the case of musculoskeletal pain, also impacts their mobility. Chronic pain doesn't just impact an individual, it really impacts the entire family. So you may see siblings really struggling, potentially acting out or not doing well in school when all of the attention is kind of focused on the individual with pain. I wanted to go through a case throughout our talk. This is one of our patients who had amplified pain, actually specifically complex regional pain syndrome. And I just want to illustrate kind of the progression and how long she dealt with this before she was able to receive the correct treatment. So this is a 14-year-old female soccer player. One day she was playing soccer and just sustained a simple rollover injury of her ankle. So it was managed initially as a sprain of the lateral ankle, just treated very conservatively, just rest, ice, compression, elevation, maybe staying off of it for a little while. By the time she returned to soccer, it was about 6 months later, and the pain recurred immediately as soon as she got onto the field to run. So she returns back to her original provider, who sent her to physical therapy for treatment. Unfortunately, despite these interventions, her pain continued to persist and even worsened slightly. So she returned again to her orthopedist, who ordered an MRI of the ankle as well as some Lyme testing. The MRI definitely showed some edema and ligament thickening, and there was concern for Lyme because she did have 3 positive bands, but active infection was ultimately ruled out by infectious disease. Due to the findings on the MRI and her continued pain, she did undergo ankle arthroscopy and debridement, followed by more physical therapy to try to rehabilitate from that. Despite another 3 months of physical therapy, the pain again persisted and now is beginning to worsen even further. So, what is amplified pain? So amplified pain is a very complex, multifaceted condition with sustained levels of intense nerve and muscle pain. Typically, we see this in the setting of injury, but can also be seen in the setting of various illnesses as well as psychological stress. There are certain risk factors for the development of amplified pain. Age, certainly one of them. As I mentioned earlier, chronic pain we tend to see a little bit in those preteen, adolescent years, much more frequently than early childhood. We do see it more in girls, tend to be people with more of that type A personality, which may be like many of us in here today. There are certainly individual and genetic risk factors, and certainly children with any pre-existing mood difficulties are at higher risk. So with amplified pain, instead of those nociceptive signals following the normal pathway that I discussed earlier to the sensory cortex, there's kind of this abnormal short-circuiting where the signal kind of goes to those neurovascular nerves as well, which causes constriction of the blood vessels, reducing blood flow and oxygen, leading to further buildup of lactic acid and other byproducts. And then this worsens the pain signal, which then tries to send its signal back up to the sensory cortex and goes through that abnormal pathway again. So this next slide here, I actually borrowed from one of my rheumatology colleagues because I felt like it really did a good job in kind of explaining what happens in amplified pain. So typically, we all sort of have a threshold beyond which we experience an impulse as painful. So in this example, let's say our thermostat is set to 80 degrees, so that signal needs to reach higher than 80 degrees to cause pain. Well, in the case of amplified pain, that thermostat starts getting set lower and lower, so things that didn't trigger pain previously are now starting to trigger pain, and then that further intensifies. That's when we start to see those hyperesthesias and allodynia starting up. The estimated frequency of widespread body pain in children and adolescents, or pediatric fibromyalgia, is about 2 to 6% of children and adolescents. There is a known relationship between localized pain and hypermobility, so it's certainly something that a lot of our rheumatologists see very frequently as well, and again, more common in sort of that adolescent 13 to 15-year-old set, and more frequently in females. Although we can see pain from that hypermobility happening even younger than the age of 5. So it's important to not completely rule it out in the younger child as well, especially when your workup isn't getting you anywhere. There are various forms of amplified pain. I tell my families amplified pain is kind of like an umbrella term. So we can have diffuse amplified pain or pediatric fibromyalgia. We can have intermittent pain where the pain is not there 100% of the time, but only when they're doing certain activities. We can have localized amplified pain without any autonomic changes, or in the case of our patient, as we'll see a little bit later, complex regional pain syndrome, which demonstrates some vasomotor and pseudomotor changes. So this is not my patient's foot, although hers was pretty similar looking. So at about 1 year post-injury, her pain is continuing to get worse. She's now experiencing color changes where the foot and ankle will look intermittently bruised and swollen. So she goes for a second opinion at this point, and they decide to trial a steroid injection to see if this alleviates some of her symptoms. Unfortunately, it does not. She winds up going for yet another opinion, and they send her back to physical therapy. By the time she returns for follow-up, she's complaining more of increasing color change, swelling, and the foot feeling cold. So at this point, it is recognized that this is likely amplified pain, and she is sent for a pain program evaluation. On her exam, she not only experienced pain over the dorsolateral ankle, but the foot was fairly cold in that area. She had color changes, looking kind of bruised, and the skin was kind of mottled over the area. Over that dorsolateral ankle where her original injury was, she had increased vascularity of her skin, swelling, along with allodynia. So even like a gentle breeze, if you kind of waved your hand over it, it would cause extreme levels of pain. And on her exam, there was also some dislocalization. So basically, if you touch the painful area, she would feel that pain spread up the leg and down into the toes. So she was given a diagnosis of complex regional pain syndrome. Some other terms that we sometimes utilize to describe this or have used in the past are reflex sympathetic dystrophy, or RSD, or newer term, reflex neurovascular dystrophy is another term that they use, but they all describe the same thing. Again, in the case of complex regional pain syndrome, it's seen more in females than males. In children and adolescents, it tends to involve the lower limb more frequently than the upper limb, which is a slight difference than the adult population. It is very rare to see this under the age of 7. I kind of already talked about some of those risk factors that increase the likelihood that something like this may develop. And certainly there are numerous psychosocial factors that play an important role in at least 80% of our patients, probably more. And it might even be the trigger of their condition. In complex regional pain syndrome, we see a classic triad of dysesthesias, vasomotor instability, and swelling over the affected area. Classically, a lot of allodynia and hyperalgesia. About 70% of patients tend to have edema over the area. The overlying skin may even look like tight or shiny. You may even see some desquamation of it. At least 60% demonstrate color changes, and I have seen almost every color. I've certainly seen like purple, red, and blue tend to be the most common, but I've seen gray and yellow and green as well pop up in some patients. Majority also have decreased temperature. As things get more chronic, you may feel decreased pulses in that area. You may see an altered sweating or changes in the hair or nail growth as well. If it goes on long enough, you can even start to see some limb length discrepancies as well. You may see various motor disturbances. So sometimes these children will present with sometimes what looks more like a functional neurologic impairment, a tremor, some dystonia, weakness as well. In terms of treatment of AMPS, the treatment is multifactorial. I think first and foremost, if you have a patient that's coming to your office and it's very clear that they have amplified pain, I think it's very important to acknowledge to the patient that their pain is very real. A lot of times by the time a patient winds up in my clinic, they feel as though other clinicians have told them that it's in their head or their pain isn't real. So that's very discouraging to them, and it makes it a little more challenging to treat. Certainly early recognition of AMPS does improve outcomes, similar to how Thea in our last talk was saying early recognition in CP does improve outcomes as well. One of the most important things in amplified pain is to try to avoid immobilization, because immobilizing that area kind of further promotes that abnormal circuitry that we spoke about before, whereas the treatment is to try to reset these nerves and get them working normally and close that short circuit back up. The gold standard for treatment of amplified pain tends to be a combination of physical and or occupational therapy along with cognitive behavioral therapy. So I kind of tell my patients we need to reset that pathway. Or sometimes I'll say to them, you know, in amplified pain, it's kind of like your pain nerve endings and your brain are speaking two different languages and they don't know how to communicate with each other. So we have to improve that connection. Typically, medication is certainly not the first line treatment. There are some instances where we will utilize the medication to help, but certainly it should be short-lived for a finite amount of time just to help patients get over that initial hump so that they can tolerate their physical therapy interventions. So the interventions that we utilize for amplified pain, again, are multifactorial. We have exercise-based treatment interventions, psychological interventions like cognitive behavioral therapy and biofeedback, pharmacologic interventions, as well as making sure that we are addressing their sleep hygiene and other stressors going on. The main goal of treatment for amplified pain is not actually to fix their pain, which may sound cruel, but really the main goal is to improve their function and make sure that they're getting back to school and social activities, walking, returning to sport if they so desire. And so what we tend to see in treatment is that function actually improves a lot faster than those pain levels reduce. So that's why by shifting the focus and focusing on how well they're doing with their function can help improve outcomes. So it's important to instruct families that I don't want you asking your child every day, how was your pain today? Because that kind of draws the cognitive attention to the pain and what they're doing rather than the function. So an example is the child may say that their pain is an 8 out of 10, but last week it was an 8 out of 10, walking around on crutches or a knee scooter. And this week it's an 8 out of 10, but they walked from the front of the school building all the way to the other end to their classroom and are complaining about an 8 out of 10 pain. So there's a big difference in what that means ultimately for the child's life at that point. Therapeutic interventions should be time limited and goal oriented. The main goal would be to fostering self-reliance and putting the child in charge of controlling and treating their pain. Again, reassurance to the patient that their pain is real, and certainly any other symptoms, including any tremors or other functional neurologic impairments, are real, and that they're not imagining it or forcing themselves to do that. I always tell families the goal, touch it, move it, use it. So in order to reset those circuits, we have to make sure those nerves are getting the input that they need to start to realize that there's not actually tissue damage that's going on when they're feeling the pain. And that's certainly very challenging. So first and foremost, as we'll see with our patient, your physical therapist matters. Not every physical therapist really has, I think, the bandwidth, same thing with any clinician, to work with these patients, because what we're asking them to do is counterintuitive, right? When we have pain, our natural response is to try to protect that area to stop any tissue damage. But in the case of amplified pain, we're forcing them to push through and do things that don't really make sense. Certainly doing hard work and pushing through your pain is a challenge. And again, focusing on function. So, we need to reset that circuitry so that touching it, moving it, using it is what we have to do. So we need to have a physical therapist that's going to encourage them to do the hard work and kind of hold them accountable while also being kind about it along the way. It's certainly not easy to watch a child in pain do the interventions that you're telling them and have more pain caused. Having the caregiver, parent, or whoever it may be absent from the therapy sessions is very important as well, because certainly they also have their own strong emotions when they're watching their child go through this work and having increase in pain. And so their emotional reactions can actually play a role in the continuation and exacerbation of the symptoms. So as we said, therapy can be very challenging and counterintuitive when you're having to push through the pain, and that's where cognitive behavioral therapy and other behavioral health supports can be very helpful. In physical therapy, there's various techniques that get utilized. Certainly desensitization is paramount, right? So touching that involved area with various textures, moving it both with active assisted range of motion and then patient's own active range of motion. We want to make sure we're preventing any contracture development because they aren't moving the limb normally on their own, and then ultimately focusing on that function or return to other vocation, whether that's sports or something else. So in case anyone is not aware, cognitive behavioral therapy really focuses on how our thoughts affect our feelings and behaviors. So CBT kind of teaches children to rethink about their pain and teach them coping strategies that can help modulate the pain and motivate them to continue with the therapy. So it helps to decrease catastrophizing, it increases task persistence, it increases activity, and teaches the child that they are in control, which is really what we want them to be doing during those physical therapy sessions as well. It teaches children self-reliance and seeks to empower patients to be responsible for their own pain management too, which really helps progress these patients further along and more quickly. Really quick, although not the mainstay of treatment by any means, and I certainly try to stay away from medications when I can, but there are various medications that we sometimes utilize to help either reduce the allodynia or reduce the pain just slightly so that they can kind of push through their therapy sessions. For the most part, non-steroidal anti-inflammatories don't tend to do much by themselves for patients with amplified pain. It's certainly worth a try before sending them on, but typically we're not recommending those. Sometimes we'll use some of the tricyclic antidepressants, so amitriptyline, nortriptyline at lower doses. Certainly gabapentin has been around for a long time, and even moving on to pregabalin or Lyrica, we do sometimes use that. Sometimes if we're catching amplified pain, particularly complex regional pain syndrome, early, we'll initiate systemic corticosteroids. We kind of take that from adult literature. The steroid can not only help reduce certainly inflammation, but it can stop that further progression or further short-circuiting of those pain signals and can also treat the underlying pain. Typically, this needs to be initiated within the first 6 months of the child developing amplified pain to have a better chance of success. So if they're beyond this point, it's rare that I would even try this just because of the side effect profile that can be associated with it. Certainly in some patients, sympathetic blocks are available, although it is very challenging to get that for someone who's under the age of 17. There are very few people, and depending on where they work, that will be able to do those blocks in pediatrics. That can help with also not only treating complex regional pain syndrome, but also identifying whether that is in fact the diagnosis. We would certainly avoid opioids at all costs. They don't fix the pain. They don't do anything to treat that underlying issue that we're having. And so we just stay away completely from that. So going back to our patient, when she first came to see me, she was about 17 months post-injury, and she had already been in physical therapy that she was referred to right before she was given the amplified pain diagnosis. So we gave her some desensitization exercises to work on at home, but she wanted to continue PT with where she was attending. She came back about 4 weeks later for a follow-up visit with me, and not only was she not doing any desensitization at home, she wasn't even doing it in therapy, despite us updating her prescription. In fact, the therapist that she was working with had told her, "I'm here to work on your strength and stability, not your nerves." So upon hearing that comment, we had her stop physical therapy there, and we really talked about doing that desensitization at home while waiting to get her in to one of our therapists with some amplified pain experience. Unfortunately, another month after that, she sprained the same ankle yet again in the exact same location. So her pain definitely flared up, but working together with our orthopedic colleagues here, we were able to completely avoid immobilization and avoid non-weight bearing on that, so we could continue to kind of push her through that amplified pain recovery. By the time she was 21 months post her initial injury, she finally got started with a physical therapist with extensive amplified pain experience. We were unable to find a psychologist to actually do cognitive behavioral therapy with her, but luckily our physical therapist has some experience in incorporating these into his sessions. She attended 14 sessions in total. She missed a few because of summer vacations, but finally, by 2 years post-injury, she is completely pain-free, full resolution of her symptoms, and she has successfully returned to her preferred sport of soccer. So I think the most important takeaways from my talk today is that amplified pain is complex, it's multifaceted, it's not just about injury and pain, it's about a lot more. Early recognition is certainly helpful. It's important to avoid immobilization. Medication alone is never the treatment, and in fact, we avoid it if we can. As we saw in our patient, the actual physical therapist who is treating the individual can be very important, and cognitive behavioral therapy plays a very large role in treatment. And so that is all. If anyone has any questions, I'm happy to answer.
Waiting on questions from the audience. I have one question here. I think as orthopedic surgeons, we probably see quite a few of these patients that come in, and you can identify them quite quickly based on their medication list. They tend to be already on, antidepressants, ADHD medications, anxiety medication. That's a fairly simple conversation because they already have the psychological therapy or psychiatry therapy going on. How do you approach the patient that comes in that you're diagnosing with AMPS that doesn't already have that on board and doesn't have a diagnosis? How do you bring it up with them without causing them to, become even more, I guess, caught up in a shell or shut down and want to get out of the room, so to speak?
So I definitely let people know that when you have pain, right, at first we expect it to be like any other pain that we had before this. We expect that the injury heals and the pain goes away. And when it doesn't, right, at first people tend to get a little bit frustrated that it's still going on, that they're no better. Then they start to get angry because they're seeing a lot of doctors and nobody's fixing the problem for them. They're not getting any better with things. And ultimately, unless there's something different about the way your brain and mood works, it's going to make you feel depressed. It's going to make you feel sad and down because this isn't happening to your friends, right? This hasn't happened to anyone. Why is it happening to you? So we're frustrated and we're angry and we're sad and annoyed about all of this. And at any point in time when our mood is negative, it actually makes our pain worse. It makes it hurt more. It makes that pain last longer. And then in turn, what happens next? Well, it makes our mood worse, which makes our pain worse, which makes our mood worse, makes our sleep worse, which also makes our pain worse, and we get trapped in the cycle. So in order to treat this and recover fully, we need to break the cycle. So we can't just treat the mood changes or just treat the pain. We have to treat you as a person, and we need to have multiple interventions in order to break that cycle.
You had mentioned towards the end of the talk that you were having trouble trying to find psychiatric help for some of your patients. Is there I guess, a department that here at Hackensack Meridian or in Jersey Shore that you can send to, or are we using outside
Yeah,
physicians?
I mean, we certainly can send to our psychology and psychiatry colleagues here. I think sometimes it's hard because they have a lot of patients too,
Right.
so it's certainly hard to get kids in for regular treatment the same way it can be for all of us here. But we do have that. There are some folks in the community, but a lot of these clinicians don't take insurance.
Correct.
So that's also challenging to families.
I know in a lot of the other comprehensive AMPS programs throughout the shore area that they take that multimodal approach and that they have these either AMPS specific psychiatrists or even just a sports psychiatrist that can help out. It would be helpful to probably have that down here as well.
Absolutely.
Wink. All right. We have some questions.
So unfortunately, I've had a couple of patients with CRPS that it progressed to integumentary lesions. Is there a benefit from a pharmacological intervention for that patient subtype?
Probably. I mean, right, a lot of times part of the reason we're seeing that is because they have altered sensation in that area. And so though most of the time it's allodynia, everything that touches that area, right, is painful. So sometimes when there's something that's actually causing tissue damage there, they're not realizing that it's something.
So she developed punch-out lesions and blister bullae from it. So that's where she was managed by a primary care doctor too. So it was an ugly situation, but definitely a complex case that she still has scars actually all over her body from it.
Wow. Yeah, no, I don't have any, unfortunately, specific recommendations for medications in that.
Now, I know this is a pediatric orthopedic symposium, but you mentioned earlier in your slides the age group of 14 to 17-year-olds or 11 to 17-year-olds. Would you consider the chronic migraines or abdominal migraines in this student population or children's population as a subset possibly of amplified pain?
Absolutely.
And would you treat it the same way?
Yes. So you can see amplified pain in any condition. So we do get a lot of like functional abdominal pains, right? That they're really struggling. They're not sleeping. They're not attending school. We have a lot of kids with chronic headaches who, are seeing our neurologists and maybe have trialed various medications without any success whatsoever. So in that population, it's certainly important to think about amplified pain. In the case of headaches specifically, we've found, or in the past when I did have access to a multidisciplinary program, occupational therapy combined with cognitive behavioral therapy can also make a big difference. And then certainly sometimes we'll even have kids post-concussion who develop amplified symptoms as well. So a lot of times getting also physical therapy involved to help work on like a return to run program or return to other types of physical activity can be very beneficial too.
Do you find that AMPS and functional neurological deficits like to couple together?
Sure.
Could you touch on that a little?
Yeah. So though it certainly doesn't happen in 100% of patients with amplified pain, certainly I have seen a lot with functional neurologic impairments as well. So one of the tough cases I had was actually a child who had abdominal pain. He actually developed it after having a viral illness, and at that point he couldn't keep food down anymore. Subsequently, he developed leg pain and amplified pain in his ankle. He then went on to develop difficulty with his speech. He was no longer able to speak, and when he did, despite being 12, he sounded like he was about 2 or 3 with speaking. So there's a lot that can go on, and a lot of times I explain functional neurologic impairment to families in a very similar way to amplified pain, or sometimes I describe it as a painless amps, or, instead of pain, your body and your brain aren't communicating properly, and so we need to help reset that circuitry so that they can communicate.
Looks like we have a few web questions here. Let's get a few in. You talked about the desensitization techniques were important to your patients in that specific case. Do you find that desensitization techniques are important for every patient with AMPS, or is it more specifically just for CRPS?
Every patient
Yeah.
with AMPS, and even sometimes too, like just weight bearing can be desensitizing as well, depending on what's going on with them functionally.
Another question is, I have been struggling with compliance of HEP for desensitization. Do you have any recommendations on how to improve compliance, as most of these patients seem to consider it boring or silly, and sounds like they're treating patients in the 12 to 21 age range with AMPS?
Yeah. Typically utilizing different techniques. Sometimes I'll have patients watch videos of different techniques. CHOP actually has really good videos on desensitization online on their website that I'll even sometimes refer families to. Dr. Sherry has been treating this for a long time. He's got lots of experience, and they actually tend to show real patients there too. And so sometimes that helps to motivate individuals when they're seeing someone else progress.
One more question. Have any biochemical advances been made to quantify the changes and how to reverse them?
Not that we can use in daily practice.
Can we scroll down? Oh, Lord. Next question. Would you say you have increased rates of AMPS and CRPS since COVID?
I don't know that I've seen increased. I would say I've actually seen an increase in POTS for sure, presenting in clinic. But I would say the cases are certainly more complex since COVID. We're seeing a higher percentage of patients that are more challenging to treat or who have more involved or significant symptoms.
Looks like I skipped the first question, is how do we refer patients to you? I assume we can put in referral information in the post-talk notes somehow?
Yeah. Absolutely.
One more. Do you have some sort of desensitization protocol or some guidelines that you typically follow with these patients?
Yeah, typically, we'll have them do it in physical therapy, but I tend to tell patients I like them to spend like about 5 minutes at least on each affected area, more than once a day, typically, 3 to 4 times a day. For patients who haven't been attending school, they probably have the capacity to do that every hour. But certainly for our children who are making it to school, we'll take 3 times a day and using various textures, temperature, modalities.
Have you ever considered using EMDR for patients with it?
So some patients have utilized that. I think the recommendation tends to come more from our behavioral health colleagues who, when the child is getting treatment with them, they find that they may benefit from EMDR.
Another question about yoga, and has it been effective in AMPS?
Absolutely.
Yeah, Pilates
Um,
as well.
Yoga, certainly even like Reiki, acupuncture have been helpful as well.
Final question here. It looks like, what are your thoughts regarding other forms of mental health counseling other than CBT, like existential talk therapy, focusing on acceptance and meaning making versus thought restructuring?
Absolutely. Certainly, CBT can be challenging to find and utilize. There are patients who, even pre existing, have more mental health, mood issues that are probably a big trigger for their treatment. So, yes, other mental health modalities can be helpful as well.
All right. Our next talk is going to be by Sarah Bayevsky. It's going to be on juvenile idiopathic arthritis, which some of us may formerly know as juvenile rheumatoid arthritis. Sarah is a rheumatologist for Hackensack Meridian. She is also the Associate Program Director for Pediatric Rheumatology Fellowship for Hackensack University Medical Center. She attended the Zucker School of Medicine at Hofstra for medical school and did her residency at Vanderbilt. Fellow alumnus, go Doors. We rolled the tide down to the Cumberland. All right. Come on in.
All right. Can everyone hear me okay?
We can hear you.
Okay. Okay, wonderful. Thank you. I'm hearing an echo. I'm not sure if there's a way to maybe turn off the mic in the room. Oh, that's great. Okay. Thank you so much. Okay. So thank you so much for inviting me. I'm really excited to talk with you today. And as was mentioned, I'm going to talk with you about juvenile idiopathic arthritis. And hopefully this is really specific for the pediatric orthopedic surgeon. Look forward to the Q&A afterwards and happy to answer any questions. Okay. So this is what I'm hoping that we'll cover in the next few minutes. First, I really want to define what do we mean by juvenile idiopathic arthritis or JIA and what are its categories? What are some key features of JIA and when should you refer to rheumatology? And then let's explore some perioperative and surgical management of patients with JIA. Okay, so first, why is it called juvenile idiopathic arthritis? And as was already mentioned, it used to be called juvenile rheumatoid arthritis, but the name was changed. So juvenile really refers to the fact that patients need to present before their 16th birthday to be categorized as having JIA. Afterwards, they tend to be categorized as having an inflammatory arthritis of adults. So they might have rheumatoid arthritis, for example. Arthritis really refers to the fact that there needs to be joint inflammation, and it's a chronic arthritis, which is defined as being present for at least 6 weeks. So this is really important because it differentiates from all the causes of arthralgias or joint pain. Really, there needs to be signs of inflammation. There needs to be swelling, limitation of motion, stiffness, especially in the mornings, those kinds of things. And so this is just an example from the American College of Rheumatology image library, where you can see inflammation of various joints in the hand. And then idiopathic. So idiopathic, as you all know, is really just referring to the fact that there is no underlying cause. But the reason that this came to pass was that the rheumatoid arthritis in adulthood had a certain character. It presented in a certain way. It tended to have overall a poor prognosis, meaning most patients had it for life once they had it, and often had severe deformities in their hands and other joints. And that's not necessarily true for JIA. And so in an effort to distinguish it from rheumatoid arthritis, the name was changed. And I think it's also important to say that not only do we not know what the underlying cause is of juvenile idiopathic arthritis, but it's important that it's not due to something else. The arthritis in childhood is not from something else. And so this isn't a list that we won't go through in its entirety, but I just want to show that there are so many other things that can cause joint pain and swelling, some of which have been discussed today at the symposium. I'll just draw your attention to trauma as something that you obviously see a lot of in orthopedics, and so something that needs to be differentiated from JIA. And then there are other things that are always in the back of our minds, things like malignancies, patients who have certain restrictive diets can get swelling in their joints, certainly infections, CRPS or complex regional pain syndrome, as was mentioned in the prior talk. And then from my point of view, I need to distinguish it from other rheumatologic diseases. So lupus can cause inflammatory arthritis, vasculitis can do that, dermatomyositis can do that, and so on. And so there's a lot that can cause joint pain and swelling. And what we do in rheumatology clinic is make sure that it's not any of these other things. And then we sort of diagnose patients with JIA if they meet the criteria for JIA and they don't have one of these other conditions. So what are the categories of JIA? So there are really 5 main categories, which are listed here. And on the left, you'll see a list of JIA types that really have to do with joints and joints alone. There are a few other characteristics, but really we're talking about joint inflammation. Oligoarticular is the most common cause of JIA, or most common category of JIA. Almost 50% of patients with JIA have 4 or fewer joints involved. If you have at least 5 joints involved, then you're categorized as having polyarticular JIA, and it's subcategorized based on whether your rheumatoid factor is positive or negative. And the reason for that is positive rheumatoid factor polyarticular JIA tends to be the child version of rheumatoid arthritis, whereas RF negative polyarticular JIA is really more like oligoarticular, in that it can present in a younger age group, often 1 to 3 years old, compared to RF positive polys who are more in their teenage years. And the real difference only has to do with the number of joints. RF negative is at least 5 joints, and oligo patients have 4 or fewer. Enthesitis-related arthritis is sort of the juvenile equivalent of spondyloarthritis in adults. It tends to affect the sacroiliac joints and other entheses. Often the areas around the patella, for example, the Achilles heel around there can be involved as well. And it can be associated, in addition to sacroiliitis, with inflammatory bowel disease. So we might want to, if you're thinking about enthesitis-related arthritis, we ask questions about inflammatory bowel disease of Crohn's or ulcerative colitis. And then the last category that really is more joint specific is psoriatic arthritis. Similar to the adult form, it can cause psoriasis in addition to arthritis. It can also cause things like dactylitis, where you get a whole soft tissue swelling of an entire digit on the hand or on the foot. And so those are sort of the main symptoms that you'll get with psoriatic arthritis. I put systemic JIA on a completely different side because it's really an entirely separate disease. There are many who don't really consider it to be a type of JIA in the way the others are. In adults, it's called Still's disease, systemic JIA. So we sort of think of it as the ugly duckling of JIA, if you will, where they're really very separate. Systemic JIA patients, as the name would suggest, present with systemic symptoms. So these patients, I think, are much less likely to present into the orthopedics clinic. They're often in the hospital because they have fevers, unexplained rashes, hepatosplenomegaly, lymphadenopathy, pleuritic, like they have pericarditis or pleuritis. So they really have a whole host of other symptoms. The thing that relates them is that they do also get arthritis, and it can be more quickly destructive. So it is important to identify systemic JIA patients early. But I think this is something that you're much less likely to see compared to the types of JIA on the left. Okay, so shifting gears a little bit, I want to show you just briefly about medications. I know that we'll be the ones in rheumatology treating it, but just so you have a sort of a bird's eye view of all the medications that are available for patients with JIA. We've really come a long way. In the early 1900s, it was really just aspirin and gold therapy that was available for patients, and JIA patients were often in wheelchairs or using walkers and overall had much poor prognoses compared to more recently. The advent of cortisone, steroids taken by mouth or as injections, followed by NSAIDs, and then as the first DMARD or disease-modifying anti-rheumatic drug, methotrexate, was really changed the game completely. And then since the 2000s, there's really been an explosion of different types of DMARDs and biologic medications, and even bone marrow transplant for very severe cases. Cortisone is something that we're using a lot, especially in the oligo patients who have one joint that's affected. They may not even need a systemic medicine. Maybe we can just inject the joint that's affected. NSAIDs are something that can be used definitely starting in orthopedics clinic before even patients are seen in rheumatology clinic. If you're going to use NSAIDs, we just recommend a standing NSAID like meloxicam or celecoxib or naproxen, things that are 1 to 2 times a day, just to increase adherence and prevent some of those ups and downs in their response. And then methotrexate is often the first medication that we try for patients with JIA. And after that, the TNF inhibitors circled here in pink, these 5 are often our next go-to, but we really have a whole host of other medications that we can use, which is very exciting for us. And that's why our patients, for the most part, look like this girl here. I want to take a brief break from this talk to just look at a case, and then we'll go into some of the keys that I would love to impart to you about patients with JIA. So let's say a 3-year-old girl presents to the orthopedics clinic with a limp for the past 2 months. Her abnormal gait was first noted after a fall on the playground. Her left knee has been persistently swollen since that time. Parents are telling you that the knee seems stiff in the morning, but seems to loosen up throughout the day, and it also improves with ibuprofen. And her primary care doctor referred her to orthopedics for evaluation of her knee pain. You notice on her exam that she has pain, swelling, and limited range of motion of her left knee, but she's able to bear weight. So I think this is the type of patient who you might often see in orthopedics clinic. And I want to present 2 different paths that this patient may go down. In the first case, you find this exam finding on, you see that she has knee pain and swelling. You get x-rays and they're negative. But given that she started with trauma was sort of where all the pain was first noted, you suspect an occult fracture, and the patient is placed in a cast. And she's in a cast for several weeks, and then she returns, and you find that she has not improved. Or you notice the left knee pain and swelling, but when you zoom out, you notice that she also has arthritis of the right elbow and the left ankle, in addition to that left knee, and you also notice a 1 centimeter leg length discrepancy. So this is something that we often see in our clinic. And I posit to you that the patient on the left could be a diagnosis of JIA that's missed, and the patient on the right could be a diagnosis of JIA that's promptly made. And so what I want to really focus on the next few minutes is thinking about what are the keys to making a diagnosis of JIA. What are the things that we can do in orthopedics clinic even before referral to rheumatology? And then what are the things that we're looking for in rheumatology to have patients treated as soon as possible? So let's go into those keys of JIA. So these are sort of my 8 practical tips. So first of all, coming out of that case, I think really important to say that if one joint is swollen, check the other joints, because it could really make the difference between a patient who goes a long time without a diagnosis and a patient who's promptly diagnosed. This is an example, again, from the American College of Rheumatology Image Library of a patient with a leg length discrepancy from, this is sort of a chronic finding because of not having a prompt treatment for JIA. And so in addition to leg length discrepancy, you can also look for thigh atrophy. These are signs of damage, things that you wouldn't expect from a short period of time, and things that let you know that the symptoms that the patient had, even though they were first noted after a fall on the playground, had likely been going on much longer. And that really was a red herring that she had fallen on the playground. Second, don't forget the temporomandibular joint, or the TMJ. So up here, this is a joint that's actually been long called, even in the rheumatology literature, the silent joint, the forgotten joint, because you can't often see swelling, and patients in kids especially often present with asymptomatic symptoms. They don't really have symptoms. They really just over time develop these chronic deformities. So you can see facial asymmetry as shown here in these pictures by David Sherry, who the previous speaker just mentioned actually. And in addition to that, you can get chronic orofacial pain, you can get difficulty chewing, micrognathia. So there are a lot of findings that you can have, and these can really persist into adulthood. Studies show that approximately 40 to 80% of patients with JIA have TMJ involvement. We think maybe more along the lines of 40% now compared to 80% in the past when we didn't have as good treatments, but it's very common. And so it's something that can be evaluated without any kind of imaging or anything in the clinic. Okay, third, think about the eyes. So a good proportion of patients with JIA have uveitis, or inflammation of the eyes. This is an example of, you can see a pupil here that's not round and regular like it should be, but instead has these irregularities. These are called synechii. They're adhesions between the pupil and the iris, and they're a result of long-term inflammation of the eyes. Uveitis left untreated can lead to blindness. And most patients with JIA have asymptomatic uveitis. They don't have a red eye, a painful eye, photosensitivity, those kinds of things. The only way to pick it up is by chronic damage, which this you can see with just the light on your cell phone. But if you want to catch it earlier before this happens, when there's inflammation, but before there's damage, it requires a slit lamp exam performed by an ophthalmologist. And so if you're wondering about a patient with JIA, we refer all our patients who we make a diagnosis of JIA at diagnosis to ophthalmology, because we don't know which started first and how long any potential asymptomatic uveitis has been going on for. So this is something just to keep in mind, especially if they have eye complaints, but even without it, to think about referral to ophthalmology for that evaluation. Of course, we're always happy to help if there are any questions about whether patients should be referred. Fourth, ask about other symptoms. So when we talked about the different categories of JIA, I mentioned that there are a few that go along with other symptoms. So as an example, this is systemic JIA, and you can see this is the sort of classic rash that you can see with, people call it a salmon-colored rash that you can see, but there are other things too. So fevers you get with systemic JIA, chest pain because of pericarditis, and lymphadenopathy. These are all things you see with systemic JIA. Bloody diarrhea, you can see as part of inflammatory bowel disease, which is associated with enthesitis-related arthritis. Weight loss as well can be a symptom of inflammatory bowel disease, even without bloody diarrhea. Psoriasis, of course, would go along with psoriatic arthritis. Dactylitis, or that kind of sausage digit, goes along with psoriatic arthritis. And low back stiffness can be a sign of sacroiliitis, even buttock stiffness as well. So if you're thinking about, does this patient have JIA, think about associated symptoms that might go along with different types of JIA. Fifth, don't rely on labs. So unfortunately, labs in rheumatology are notoriously bad. And so the diagnosis of JIA is largely a clinical diagnosis. We do often get labs, but that's really to subcategorize patients with JIA and less so to actually make the diagnosis. So all types of JIA, except for all types of JIA have negative rheumatoid factor and CCP, except for RF positive polyarticular JIA, which tend to have RF positive and often CCP positive as well. That means that enthesitis-related arthritis, oligoarticular JIA, psoriatic arthritis, there's so many other subtypes that have negative labs. So if you send those labs, it doesn't really make or break the diagnosis. And same is true for systemic inflammation. So ESR and CRP are most commonly normal in patients with JIA. The polyarticular patients tend to have a higher burden of inflammation because they have so many more joints that are involved. And so sometimes the inflammation spills out into the blood and you can pick it up on blood tests, and they may have a mildly elevated ESR and or CRP. But certainly having normal inflammatory markers does not rule out a diagnosis of JIA. 6, going along the same lines in terms of labs, we don't want to be fooled by either a negative or positive ANA. So in terms of positive ANAs are positive in about 10 to 20% of healthy kids. I tell patients this all the time, that if I took 10 students in their class, 1 or 2 of them just sitting there in class trying to mind their own business have a positive ANA and don't have any autoimmune condition. This is an example. This is sort of just like a pictorial representation of the nucleus of a cell. This whole thing is the nucleus. This middle part is the nucleolus. And you can see all of these things around it are all antigens that an antibody, an ANA, an anti-nuclear antibody could bind to. So there's so many little things that it could bind to, and it doesn't mean that they have any particular disease. If they had something more specific that we see in rheumatology, like an anti-double-stranded DNA antibody or an anti-Smith antibody and so on, that is a very specific antibody against a specific antigen within the nucleus, and it tends to have more meaning. But a positive ANA in general just means that they have an antibody against some antigen in the nucleus of their cell, and so do a significant minority of healthy people off the street. So a positive ANA does not mean that they have JIA, and doesn't mean that they have an autoimmune disease in general. I think just important to say overall that patients with JIA can have both negative or positive ANAs. The reason we get an ANA in patients with juvenile idiopathic arthritis is that it's been shown in multiple studies that patients who have a positive ANA and have JIA have a higher risk of getting uveitis. And it's practically helpful for us because we send those patients to the eye doctor more frequently. They often get every 3 months, they're getting their eyes checked, even if they have no symptoms, for the first, sometimes few years, just to make sure that they don't develop uveitis without us knowing, and so that we can treat it promptly if it arises. So ANA does not make or break the diagnosis of JIA. In patients with known JIA, ANA can be helpful for prognosticating the risk of uveitis. 7, don't rely on x-rays. So imaging is overall not something that's necessary in all patients with JIA. Certainly if there's a history of trauma, there may be other reasons to get x-rays, and that is, that's very helpful in a lot of cases. But especially early on in the disease, x-rays tend to be normal. So if this is an example of an x-ray in which you can see findings, you can see some soft tissue swelling here in the third PIP, MCP, I should say. You get some juxta-articular osteopenia in some cases. You can even get some joint space narrowing. I think there's some here, maybe in the PIPs. But most patients with JIA have normal x-rays, especially early on. And so normal x-rays do not rule out JIA. And then my last tip is just to call us, that we're happy to talk with you over the phone if you're concerned about a patient or wondering about a patient, or of course you can send us a message too. In general, we do recommend referral to rheumatology if the joint inflammation has been going on longer than 6 weeks. But certainly if there are questions before that or questions after that, really that's what we're here for, and we're happy to help. So please don't hesitate to call us. Okay. So those are my 8 tips about JIA. Let's move into the last portion of the talk, which is really just about perioperative and surgical management of patients with JIA. You are certainly more of an expert than I am about this, but I just wanted to share a couple things that I've noticed and some of the guidelines from the American College of Rheumatology that may be useful. So this is an article actually that you may find helpful. It's from 2019. It's called Juvenile Idiopathic Arthritis for the Pediatric Orthopedic Surgeon. And it kind of goes through the different types of JIA and some pearls as well. This table from this review article goes through different surgical options for patients with JIA. And I won't go through them with you today, but I just wanted to point out a couple of things. One is the top one synovectomy, which really has some role for short-term relief of pain and swelling. The long-term improvement is more controversial, and so it's not been demonstrated in a lot of studies that having a synovectomy actually helps in the long term with patients with JIA. Arthroplasty, on the other hand, can be very helpful and is considered the definitive treatment for end-stage arthritis. It's really a last resort, but something that is helpful and necessary in some patients who have very severe disease. For patients who do require arthroplasty, it's generally recommended in order to facilitate rehabilitation that the hip undergo surgery before the knee. And then I just wanted to make a small point here that there are patients with juvenile idiopathic arthritis who have cervical spine disease or who have TMJ disease. And for these patients, it's helpful to get imaging of the TMJ or cervical spine. For the cervical spine, you want to get lateral films, flexion and extension, to look for any signs of atlantoaxial instability. And it can be helpful for patients to see anesthesia prior to getting intubated to see if there's any risk there or anything that they really need to think through or mitigate prior to any kind of surgery. So think about for patients who have neck pain or who have history of TMJ arthritis, whether that would be helpful for those patients. In terms of perioperative management, I think that something that comes up a lot is what to do with the patient's medications if they are going to go to surgery. For example, methotrexate is a medication that is recommended to be continued through surgery, whereas many of the biologics are recommended to be held for some period of time. Usually they're restarted once patients are showing signs of improvement, wound healing is going well, and that kind of thing. This is a QR code to the American College of Rheumatology guidelines for perioperative medication management. This is done, I believe, in 2022, or it's been pretty recently that it was revised. And there are a lot of medications here which are not used in JIA, things that are used in lupus and vasculitis and other things. So they may not, all the medications may not be relevant, but it's helpful maybe to have as a resource. Obviously, you can reach out to us as well if there are any questions for a particular patient. And then I just wanted to briefly mention that patients who are on chronic steroids, which is not common for patients with JIA, we really try to minimize the use of steroids because of all the long-term side effects. But for patients who are, consider whether they need to be on stress dose steroids with hydrocortisone specifically around the time of their surgery. And this is, again, something that we're happy to help with if there are any questions. So I'll go into my take-home points now and then happy to take questions. Remember that juvenile idiopathic arthritis, or JIA, is a chronic arthritis, so it has to be 6 or more weeks in patients who are under 16 years old. It's not due to another underlying condition. Early recognition, I think, is a theme of many talks today, and medication management is key. A few things we talked about are checking the other joints. Don't forget about the TMJ. Refer for uveitis evaluation. Don't rely on labs or x-rays to make the diagnosis, and then call us. And then finally, feel free to use the ACR's perioperative guidelines to assist with medication management, and just use caution in patients on chronic steroids or those who have TMJ or C-spine arthritis. Thank you so much. I'm happy to take questions. This is my email. Feel free to email me if you have any questions afterwards or if I can help with any patients.
Don't rely on x-rays? I'm an orthopedic
I know.
surgeon. What am I supposed to do?
I wasn't there to hear the gasp in the room.
Just to start, I had a couple questions, if you don't mind, Doctor. Firstly, when it comes to sending patients for blood work, so we know that only 5% of the patients with any type of rheumatologic disease have a positive RA or RF, excuse me. What panel would you recommend, if any, that a pediatric orthopedic surgeon or a general practitioner sends the patient prior to seeing you, because it's hard to get in to see you? Not you, but in general, there's only so many of you. You guys are too smart, so there's only a few of you. How can we help?
Yeah. So it's tricky. I would actually say that I don't think that they need to have labs before they see us in clinic for evaluation of JIA. I actually think that patients tend to get referred a little bit later when they have negative labs and a little bit sooner when they have positive labs. And it's not necessarily the case that that's warranted. For example, I saw a patient in my fellowship who had symptoms for 1.5 years before she came to me. She had been seen by this is not at Hackensack. She'd been seen by orthopedics, neurology, physiatry, many different doctors before she came to rheumatology, and she just had all negative labs. And people thought, well, she doesn't have positive labs, she probably doesn't have rheumatology problem. It doesn't make or break the diagnosis, unfortunately. So I would say that if there's a patient you're concerned about, a patient you have a suspicion for JIA, shoot us a message, and we can often get patients in. We have some visits with our fellow who we staff in clinic, and we do add on patients, when there are other practitioners who are concerned about them. So I would say, rather than getting labs, just shoot us a message, reach out to us, and we're happy to try to help.
Oh, that's great. Thank you. And just second part of the question is, how helpful is a synovial biopsy for you? Or not at all?
Well, well, so it's rare that we'll use it. We use it basically to rule out other diagnoses, I would say. So for example, if there's a concern about a chronic infection that we might be missing, mycobacterial infection, for example, tuberculosis, those kinds of things, that sometimes we get it. It's usually not necessary for the diagnosis of JIA and sort of the classic patient. So I would say that it's used rarely, but in cases where we're not sure of the diagnosis, it can be a useful option.
Oh, thank you very much. Wonderful talk. Turn it over to Dr. Collins.
Seems like we have a few questions here. Is there any role for daily low-dose prednisone to prevent flares in JIA?
So we don't tend to use daily low-dose prednisone to prevent flares. No, I think it's mainly to reduce the risk of side effects. thankfully, our medications tend to be pretty good for JIA. And we do use people call like early step up therapy, where if they fail methotrexate, we'll quickly move on, usually within 3 months, to a biologic. And now we have a lot of different types of biologics, a lot of biologic, and they tend to have very few side effects overall. The side effects that we counsel patients on in terms of biologics tend to revolve around the increased risk of infection. And in some cases, they do need lab monitoring, like patients with methotrexate, for example, need every 3 months to get their liver and kidneys and blood counts checked. But in general, patients do quite well. So we tend to avoid, just because of side effects, prednisone, both for use of flares, unless we absolutely have to, and also for preventive care.
Next question is, do you refer to ophthalmology or optometry for uveitis?
It tends to be ophthalmology. I think there are some optometrists who can do slit lamp exams. The way that I say to the patient is that they need to have a slit lamp exam. So if they call their optometry or ophthalmology office and it's possible to be done by an optometrist, that's totally fine. Most of the time, it tends to be an ophthalmologist who will do that specific exam.
How do you go about explaining to younger children what is going on with them? What sort of terminology do you use with them, and how do you avoid trying to scare them when you're discussing that perhaps their body is attacking itself?
Yeah, it's a really great question. And it's something I think about a lot. I'm a med-peds rheumatologist, so I treat both adults and children. And I often find actually that patients who are seen in adult rheumatology but had pediatric onset disease know very little about their JIA. And you might think, well, they've been taught about it their whole lives. They have been taking medications, but they were so young when they were diagnosed that they actually have a very different understanding of the disease compared to somebody who's older. So I think no matter what age the patient is at, it's important to think about how they're taking in that information and what we want to tell them. I think that what I try to tell them is that I guess I try to focus on their symptoms, I would say. So whatever they're feeling, if they feel like they're not able to, sometimes they don't have pain. Actually, about 25% of patients with oligoarticular JA do not have any pain, but they may feel something in their joint that may be limiting them, or they're noticing that they're not keeping up with their peers as well, or something like that. So I focus on what their symptoms are. I do try to explain like what an immune system is. I try to tell them that your immune system is the part of your body that helps you fight off infections. And in some cases, it thinks that your body is sort of being tricked and it thinks that there's an infection in your body, but there's no infection. And in those cases, your immune system can affect your own body instead of trying to get rid of an infection. And so if it affects your joints, then you might get joint swelling, whatever their symptoms are. They might get joint swelling, they might get pain, they might have difficulty moving around. It can be useful to stay away from the words like attacking or things like that. But I think if you focus on their symptoms and the fact that it's their immune system that's involved, and so what we need to do is give them medicine that helps their immune system work better. That's sort of what I try to explain to them. And then I do think as they get older, it's important to have that conversation iteratively. The conversation that you have with a 5-year-old about JA is different from the conversation you have with a 10-year-old and a 15-year-old and so on. And so I do try to come back to it at periodic intervals and ask them, tell me about what's JIA, or if they talk to their friends about it, which, I give them the option. I ask them like, what do you talk, how do you explain this to your friend? And as they get older, they get a better and better understanding. Thanks for that question.
I just have a question. Is there any data on the use of hyaluronic acid injections for joint preservation?
So we've used it in osteoarthritis, and sometimes patients will have osteoarthritis. They get early onset osteoarthritis from inflammatory arthritis. Generally, it doesn't happen as in childhood, although it can, especially in teenagers and patients with really severe arthritis. But generally, for patients, we're using cortisone or steroid injections, and it's less common, I would say, to use hyaluronic acid. I've used it in my adult patients on occasion with osteoarthritis, but I think it's less common with pediatric patients, but something to keep in mind. And I was just reading there's now some studies going on about NSAID, intra-articular ketorolac or NSAID injections. I'm very curious if any of you have used them. It's not something that I've used before, but I'm seeing that it's getting some press.
We have a final web question. Does JIA ever completely resolve, and can it flare into adulthood?
Yeah, everybody's a little bit different. And I tell patients, unfortunately, that I don't have a crystal ball to know what type of arthritis they will have. There are specific prognostic factors that I can use to at least make some, just have some sense of whether they will or they won't, but it's not perfect. So as an example, oligoarticular arthritis tends to have a better prognosis than the RF positive polyarticular arthritis, which tends not to go away as much. There definitely are patients with oligoarticular arthritis for whom the symptoms resolve. And there are also some patients who have symptoms continuously, and there are other patients whose symptoms wax and wane a little bit. So it can be a little bit different. There are also specific joints, like wrist and elbow tend to be joints that if those are involved, it overall portends a more chronic course. So there are certain things that we can look at to give them a sense, but I generally say that it will all depend on how they respond to the medication, and that we generally keep patients on medication for quite a while before we start taking them off. Like I would say at least a year generally of being symptom free before we pull back on their medications, just because we don't want them to flare right after we start it. But if they're showing that they're doing well for a period of time, then we can start weaning medications. But it's really hard to know about weaning. It's the subject of great debate among rheumatologists. We know more about when to start medications than we do about when to wean them.
All right, thank you very much.
Thank you.
All right, our final talk tonight will be by Dr. John Lentz, my esteemed colleague and fellow practice partner. John is board certified in pediatric orthopedic surgery. He specializes in a lot of things, but certainly one of his key practices is in treatment of spinal deformities. He went to Rocky Vista University to get his doctorate in osteopathic medicine, completed his residency in Northwell Health, and went to the esteemed Johns Hopkins for his pediatric orthopedic fellowship. Come on down, John.
Okay, thank you very much for having me, and thank you for staying awake. And this is the last one, so everyone get ready. And everyone at home, thank you as well. There's a lot of thank yous to start off, so thank you for everyone for putting this together. This is my second time here, and I look forward to the next one as well. Although I don't love making the PowerPoints, I do like being here, and I learned a lot from all the presenters today. I truly will change some of my practice because of every one of your lectures that I've heard, so thank you all for that. Pediatric orthopedic surgery is an amazing field. I'm very happy to be involved in it, and one of the beautiful things about it is we can specialize in so many areas of the body, and we might be seeing patients for their spine or their knee or their wrist, hand. It could be anything, but one thing that I'm truly passionate about, I'm passionate about all of it, but is scoliosis. So we're going to talk a little bit about scoliosis today. I'm going to go through a few things. So none of us have disclosures. We should probably be better business people and get some more disclosures. I'm still in that group. Anyone has any for me, I'll take them. Our objectives. We're going to define idiopathic scoliosis. We've heard the term idiopathic a few times already tonight, but we'll go through that again. There are many types of scoliosis. We're going to talk about how we diagnose it, how we treat it, and kind of go through some cases of what it looks like when we do treat it. Before I dive into that, I always like to give thanks to a couple of people who trained me, and incidentally, they trained a few people in this room, which is interesting. So Dr. Sarwahi, Dr. Amaral, Dr. DeMoro, Dr. Graywall, and Dr. Sponseller, they've trained a couple of us in terms of scoliosis. So kind of everything I've done has come from them, and I hope to build on what they've taught me, and we're doing that well here. I could add Dr. Haynes to that, but I didn't want to make him feel old. He is one of the key reasons we have a scoliosis program here at Jersey Shore that has been so successful in terms of getting the safety protocols, the physical therapy team, the anesthesia team, the neuromonitoring. Everything was put together before I got here, which makes my job easier, makes me more able to take care of these kids, and Dr. Collins as well before I got here. So we all work together really well. We have a great team. So thanks, Dr. Haynes. We'll put your picture up there next year. So what is scoliosis? Scoliosis is a curvature of the spine. It's most commonly thought of as just a bend when you're looking straight forward at somebody, a bend in the coronal plane. But truly, a better way of thinking of scoliosis is that it is a rotational deformity. It's a twisting of the spine. We define it based on that coronal frontal plane of how much curvature there is and how much bend there is between the most tilted of the vertebrae to the other most tilted vertebrae. And anything greater than 10 degrees we call scoliosis. But truly, that spine is twisting. We're losing some of the normal sagittal profile that we see. So thoracic kyphosis is lost typically in this and is becoming hypokyphotic. The rotation we'll see on that Adams forward bend test that everyone probably has heard of before, we'll go over in a little bit, that the rib cage is rotating with that spine, causing that deformity. And these are key things in how we treat this as well and how we diagnose it. And then we're going to look at mainly adolescent idiopathic scoliosis, so our 10 years and older onset. But I want to mention infantile and juvenile idiopathic scoliosis as well because they're interesting. They're not quite as common, and each one of these could basically get its own lecture, but we'll touch on a few of the important details. So infantile, 0 to 3 years old, and juvenile, those are our early onset scoliosis. Even for our idiopathic ones, we still have to confirm it's idiopathic, right? Idiopathic means we don't know why it happens. We need an MRI in these patients at some point, and that is challenging. A baby getting an MRI means general anesthesia or sedation. So there comes with a little bit of risk, and our anesthesiologists are great, but to time that MRI is really important, especially if you're going to be getting an MRI of the entire neuraxis to rule out syrinx, Chiari malformation, tethered cord, all these possible things that could be leading to scoliosis, making it not truly an idiopathic, but maybe more of a neurogenic scoliosis. If you're going to be doing all those tests for an hour and a half of MRIs, most of these kids are not sitting still. And we have to time that to make it more appropriate and more safe for them without missing something that potentially could be causing their deformity to be getting worse. Our infantile scoliosis, I think, is extremely interesting because it's one of the few forms of a progressive scoliosis that we can cure without surgery sometimes. So curves that are 30 degrees or greater or we think are progressive can potentially be treated with a cast. And this is a Risser cast, and it's not super comfortable, but kids do really well with it, as you would imagine. They kind of figure it out. The cast is changed every 2 or 3 months. Sometimes it could be 5+ casts, but this can lead to a straight spine. And sometimes with just maintenance of the brace, or sometimes not at all, that patient grows up to have no scoliosis. So that's a really cool thing. And we don't see it very often, but when it comes our way, it's a really satisfying case. Juvenile idiopathic scoliosis, so slightly older, 4 years to 9-year-old kids. It's similar. Casting is a little bit tougher in this age group, and the bracing technology has come a long way in terms of form-fitting braces. So oftentimes we're not casting these, but more using a form-fitting brace, and we'll go through some of those braces later as well, to try and prevent this from getting worse. At some point, with really severe progressive curves, we have to go with surgical intervention for these patients. It's much less common for our infantile, but for our juvenile, it does happen once in a while. And that might be a growth-friendly construct. So what is a growth-friendly construct? And why do we care? Well, if you fuse the spine, which is typically what we'll do for our adolescent patients, their spine's going to be pretty short. Their thoracic cage is going to be short. As the rest of their body grows, their lungs are not going to be able to have the same space that they need to develop. If you fuse just the back of someone's spine, they might get something called the crankshaft phenomenon, which means the front still grows, the back stops, and the spine twists around that construct. So you still get progressive deformity. So you're not accomplishing your goals in that patient, and you're probably making them worse. In a growth-friendly construct, you can fuse a very short segment at the top, a very short segment at the bottom, and place something spanning in between there. And what that does is it allows lengthening of that rod. In the past, that was just done by repeat surgeries every so often to actually go in, open just the central segment, and lengthen the rods, close it back up every so often. That allowed the patient to continue to grow and progressively correct their deformity. This is a novel technique which you're looking at called a magnetic growing rod. It's incredible, really, when you think about it, because we put this device in, and then in the office, we check them with this little magnet, which sticks to their back and tells us exactly where the transducer is for it. And we use this device at the very bottom here to lengthen those rods magnetically through their skin. That's incredible. And it's a very cool surgery. Although I'm not supposed to say cool surgery. I know people tell me not to say that because no one wants to think of that as cool. But it is amazing technology, and it really has revolutionized things. There are a few other types of growth-friendly constructs, but this one I think is incredible. So this is a great option to sometimes just buy time by minimizing the risk of this deformity progressing to a level that would be almost impossible to treat when the time comes that they might need that definitive fusion surgery. And some people are even trying to ride this out as a definitive treatment, see what happens down the line. So that's not really FDA approved, but we'll see what happens. So let's now talk about, I just wanted to touch on a couple of those things for the early onset. The adolescent stuff is what we'll really go into. We'll talk about how we diagnose it, how we treat it, what we see, what my exam looks like in the office. So this is a pretty typical adolescent idiopathic scoliosis patient, except for one thing, is that it's a male. Typically, in bigger curves like you can see this person has, it's like a 10-to-1 female to male ratio for the bigger curves. So it's much more common in our female patients. But what you can see on this patient already is the shoulders are asymmetric. The scapula are asymmetric. The spine, you can actually see the curve on this patient. You can see the muscle mass difference on the right side versus the left side. And some of those things by themselves don't matter. I often tell patients in the office when I'm looking at them, and I'm telling them, oh, there's a little bit of shoulder asymmetry. I have to remember I'm talking to kids right now, and what they're hearing is I'm trying to tell their parents and them at the same time without offending them. And I often tell them, you know, I actually have more asymmetric shoulders than you, and I have no scoliosis, which is funny, because when I started practice, I took an x-ray of my spine because I assumed I had scoliosis, and I have none. I just have a weird body, I guess. So we're not built symmetrically is what I try and hammer home for our young patients, that this doesn't mean anything. Adolescent idiopathic scoliosis is a young, healthy person with a little twist in their spine. And I really hammer that home as many times as possible. Play sports, have fun. You're no different than any of your friends except your spine's a little twisted. And your friend might have a weirdly long second toe. We all have a little bit something different about us, okay? That's an important thing for these young patients. There is a family history, so there's a genetic component, but not everyone within a family will get it. We often ask that question as part of our history to find out, is there somebody else in the family that has had this? Did they require bracing or surgery? How severe was it? Do you have a younger sibling that we need to maybe screen and make sure that when their time is right for them, that we take a look at them? And then that idiopathic question again, just want to make sure that we ruled out other things. Idiopathic means we don't know why, which means there's not a test to say it's idiopathic. There's tests to say it's not all the other things, and then you can say it's idiopathic. So congenital scoliosis, meaning that one of the vertebrae or multiple vertebrae can be misshapen. That would lead to, as you see that little triangular shaped rather than rectangular shaped vertebrae in the picture there. You can imagine that's going to send somebody off to the side a little bit as they grow. You can also have it where in the spine where there's discs supposed to be between the vertebrae, there's an abnormal fusion on one side or the whole thing. If it's on one side, you can imagine that as they grow, it's going to tilt them off to the side again. So neuromuscular, we had some great talks earlier discussing cerebral palsy. It's one of the big things we see is spinal deformity with that. Thanks. And then syndromic, we're looking for connective tissue disorders or anything. There's a lot of syndromes out there that come with scoliosis. So we're kind of looking at the entire patient, taking the history, and really trying not to miss anything on the exam before we call this an idiopathic case. So what kind of screening stuff do I do to find out if they have scoliosis? Should I be getting an x-ray? Is it idiopathic? Or, well, really, first, who do we screen? The recommendation is kind of girls 10 to 12 years old and boys 12 to 14 years old. But I say there's really never a bad time to screen for scoliosis. The real credit goes to our pediatricians, our school screening programs, our physical therapists. Anyone who lays eyes on these patients has been such a huge help. And sometimes I'm so surprised because I do this every day. I'm looking at scoliosis, severe ones, mild ones. And half the time I'm like, in these really mild cases, I'm like, I don't know how they even saw that. They did a great job. And I'm so happy that they did that. So when they find a mild scoliosis in a young patient, we know it's mild. We can start treatment immediately, whether that's just observation or physical therapy or bracing, whatever it might be. The earlier you start treatment, the better. So the detection, and I know we have a school nurse in the back there that hung out for the whole thing. So you guys are doing a great job. And thank you for all that as well. But that's a huge part of how we treat this, is getting early detection of this. Here's the kind of the consensus statement from all of the different organizations that agree with that age group being the prime time. And something else to mention about this, that prime time, 10 to 12 years for females and 13 to 14 years. I don't know if you guys remember those times of your life, but your bodies are changing a lot in those times. You might be covering up from your parents and not, wearing bulkier clothes and not hanging out around the house. The younger kids, the juveniles, most of the time they get picked up by the parents because they jump in the swimming pool and the mom's looking at their back and it looks asymmetric. These kids are kind of covered up, so if they're not being screened actively, it's easier to get missed. So the history and physical, Dr. Moses mentioned this too. It's a hugely important part of this process. Do you have back pain? Back pain is kind of not an abnormal thing for kids with or without scoliosis to have. So it doesn't help just the back pain itself, but we want to know about it. We want to characterize it if it's there. Is there radiating pain? That's not really normal to have pain radiating to your arms or legs. That might suggest maybe something else more going on. Numbness, tingling, weakness, bowel or bladder issues. Those are all really concerning things that might make me think about neuraxis imaging, even for someone that looks more like an idiopathic case. Menarche is a huge factor as well, because part of how we treat scoliosis is determining how much growth someone has left. And for about 1.5 to 2 years after menarche, people will continue to grow and they have that risk of progression of scoliosis during that time. So that's typically an awkward question for me to ask a teenage girl every time they come into my office, but I pretty much do it every time, and I try to explain to them why I'm asking that question so it doesn't seem so crazy. We want to take a full look at the patient. We talked about some of this stuff already, the shoulder heights, the scapulas, the waist crease asymmetry. You typically get flattening on one side of the curve with the convexity, and on the concavity, you get a little bit of an increase on the waist crease there. These curves come in 2s or 3s typically, 1 or 2 being structural curves. We'll go through that in a little bit as well, but some of the other ones are compensatory. And the way I try to describe that is if you have one curve that's structural, meaning some of this, for unknown reason, your spine is twisting in your thoracic spine. If you just had that happening, you would be leaning to the side. So your body wants to keep your head above your pelvis, and the way it does that is it bends your lumbar spine back and your top of your thoracic spine back to keep everything centered. So those other curves may not be structural. They may be compensatory, trying to just keep you from falling over. The scoliometer, it's a great device. There's iPhone apps for it or any smartphone app for it. You don't really need the app, but sometimes this can help you if you have a number, really track the progression of somebody, especially if you're trying to manage them and minimize their radiation dose. The Adams forward bend test shows that rotation, that axial rotational component that we talked about. That spine is twisting, not just bending in one plane. It's a twist. And the ribs that attach to there are really what show us, and this will lead to an X-ray every time, this image here. A 7-degree rotation equates to about a 20-degree scoliosis. The physical exam, every first-time scoliosis patient in my office gets a full neurologic exam. And it's not like an hour long, it's like a 5-minute process. But I really try to be diligent about it, and I tell them that. I tell them, you're a young, healthy person, but I'm going to screen you because one time out of every 100, or even if it's 1 out of every 1,000, I'm going to pick up something. And in my even short career already, I have picked up 2 or 3 patients that had a syrinx that, just from catching something interesting, like they had clonus on one of their feet, or they had hyperreflexia, or they had asymmetric abdominal reflexes, which we'll get to. Something weird on the exam should always kind of trigger something to send you, and just it doesn't hurt to get a non-invasive study like an MRI, except for the time involved with it. It's not a radiation thing. It's just it's something that you can potentially alter the entire course of this process and save somebody a lot of trouble. Let me go back one. The other physical exam, I don't do this on every patient. This is a Baton score. Baton score tells us about potential pathologic connective tissue disorders or looseness in the tissues. This can be seen with anything like Ehlers-Danlos syndrome. Some of these things have overlap with like Marfan syndrome, and those things come with scoliosis as well. So that would lead us down the line of looking at a syndromic scoliosis rather than idiopathic. So we're again trying to rule that out or make sure we're confirming that it is in fact idiopathic. This is the abdominal reflexes. I challenge you to try and do this exam without the kid laughing and thinking you're just tickling their belly. It's almost impossible. I have to explain that. But this is a useful test. This is one that picked up a syrinx in a kid for me. You basically stroke away from the umbilicus, and if it's typically the umbilicus will go towards that stroke. If it happens on one side and not the other side, that's abnormal. If you can't get it at all, it's because the kid's laughing and they're firing their muscles, and it's a challenging exam. But taking the extra second to try and get them to take a deep breath and breathe and relax so that you can get a good exam and just see that, I think goes a long way. Leg lengths is another important key. So while this patient's laying down, I check their leg lengths. That can throw it off. If you have a short leg, again, your body's job is to keep your brain above your pelvis. So in order to keep your short leg in check, essentially, your spine bends. That can look like scoliosis. There's a couple ways of assessing that, but you want to get every chance you get to have all the information you have. Imaging is the next big thing. So once we've screened and there's a positive screening, it's often, we are almost always in agreement. Even if I don't see it and the pediatrician saw it, I'm probably getting that first x-ray just to be on the safe side, because sometimes they pick up things that I can't, and vice versa. So it's worth that first screening if there's any question about it, because we really don't want to miss any scoliosis. The EOS x-ray machine we're going to talk about in a second, I think, is also revolutionary. Not quite to the level of the magnetic rods, or maybe it is. We'll talk about it and you can let me know what you think. But we want to get a PA x-ray of the entire spine and a lateral view typically to check the appropriate curvature. And that's how we make these measurements. These measurements are called Cobb angles, and we're measuring from the most tilted to the most tilted of the vertebrae, and they come in these 2s or 3s typically, like we talked about. The EOS x-ray machine, a patient stands in that platform there in the orange, and it simultaneously will take an AP and lateral view with significant reduction in the radiation dose, up to 80% reduction compared to standard x-ray, and for follow-up x-ray is 98% reduction because it could do a lower dose than even the already low dose. I'm really excited because we're getting one at our scoliosis center. We've been pushing for it for a long time, thanks to Dr. Collins and Dr. Haynes, because they've been pushing for it for even before I got here, but we're finally getting one. And this is going to make just managing our patients a little bit better. We have better quality images and lower dose radiation, all better for our patients. In order to kind of understand how we treat it and why we treat scoliosis, the natural history is important. Like, why are we doing this? Just because there's a bend in the spine, does that mean we have to treat it or fix it? What's going to happen if you do nothing? And luckily, some people back in Iowa in like 1938 started this study, and they followed patients for like 50 years. And in 1992, they released a lot of the data on what happens if you don't do scoliosis surgery. They didn't do any surgery or any treatment, no bracing to these patients. And they compared it with age-matched participants that didn't have any scoliosis. And they found some very interesting things. They found that the lower curves don't really progress too much. So they looked at this number around 45 to 50 degrees as the cutoff, and that's where we get our surgical criteria. Greater than 45 or 50 degree curves will progress even when you're done growing, whereas the other ones won't. So that's our justification for, we don't want somebody with a 45 degree curve at 13 years old to have 1 degree of progression per year on average and be a 60-year-old with an 80 or 90 degree curve. Don't check the math on that. But essentially, it will continue to progress. And at that point, at 80 or 90 degree curves, you're starting to get pulmonary issues, cardiac issues, and that can start to affect your life. The interesting thing is that study also showed that these people that were never treated for scoliosis, even with severe ones, lived pretty normal lives. They did have progressive deformity, but they didn't really, like, they were able to work the same as their same people in their cohort. They just had progressive deformity and potentially had this cardiopulmonary compromise later in life. So the deformity itself is typically what we're operating on and trying to prevent future problems. So knowing the natural history, how do we treat it? Well, I always break scoliosis up into mild, moderate, severe. Try and make this easy. Mild curves, less than 25 degrees, we'll keep an eye on it. We might throw some physical therapy in there. Dr. Monteleone might be able to help them. Our Schroth physical therapy, which we'll touch on in a second as well, is an option for somebody that doesn't necessarily need a brace yet. We're going to keep an eye on them while they're growing to see if this curve is getting worse. When they hit that criteria of maybe 25 degrees or more in a growing patient, we're going to start talking about bracing, and we're definitely going to push more for that therapy because those two together work very well. This Risser score, which you're looking at here, this is something we also see on that same x-ray we take typically. It gives us an idea of how much growth someone has left. So scoliosis is always based on, or treatment of scoliosis is based on how big is the curve, how much growth do they have left. Those two things can answer a lot of the questions for this algorithm. The Risser score is the iliac apophysis, or the growth plates that's starting to ossify on the top of your pelvic brim. It starts in a reliable fashion. It starts in the very front and works its way all the way to the back and then fuses across. So Risser 1 being 25%, 50%, et cetera. And patients that are Risser 4 or 5 don't have as much growth left as 1 or 2. And Risser 0, of course, has the most growth potential remaining. So we want to use that information to decide what can we do to help this person? Do we have to continue to monitor them? What's our next step? So another way of assessing their possible or the amount of growth they might have left would be, we talked about the menarchal status. We talked about just the age range, because girls will typically stop growing around 14. Boys will typically stop growing around 16, but not everyone reads the textbook and stops growing at the right date. The Sanders classification is a great way of assessing this as well. You take a hand x-ray and you can assess, are they past their peak height velocity around Sanders 3 or 4? Are they peak height velocity being that last big growth spurt a kid's going to have, which is when scoliosis can really take off? Are they closer to Sanders 7 or 8, which a brace isn't going to do anything at that point because the patient's not growing? Our moderate category that we started to mention earlier is our 25 to 45 degree curves. And in our growing patients, they're going to get a brace. The brace is a lot, but it is the best thing we have to prevent somebody from getting from the moderate category to the severe category. When people think about scoliosis braces, they often think of this. It's not quite like that. It's more like the picture on the right. This is a form-fitting thoracolumbo-lumbosacral type orthosis. It is pushing on the apex of the curve. I also want people to always think about what is the goal of bracing, not just what do I have to wear it, because sometimes people think, oh, it's going to make my scoliosis go away. It's not going to make it go away. It's going to, while you're wearing that brace, it's going to increase or decrease your curve to a more straight position. When you take that brace off, it's most of the time going to go back to where it came from or have progressed a little bit. The goal of this is like tying a stick to a tree that's growing crooked. You might have a good chance at making it not grow more crooked by tethering it a little bit, but it might not grow completely straight. Trees have a lot more time. They might actually grow straight, but scoliosis doesn't typically grow into a more straight position. But if we can prevent it from getting worse, that's a huge win for us. Keeping someone out of the surgical range is kind of our goal, even though we're pediatric orthopedic surgeons and something that we do. Most of my job is trying to keep people away from surgery. Just to give you an idea of a couple of braces, that bottom one's starting to look a little bit more like that first brace that was a little scary, but that's typically not used. That's for, sometimes I'll use a similar brace, try to avoid the neck piece, because almost no one's going to wear that. You're not going to get compliance with a neck piece, just it's realistic. But sometimes some of our orthotists can make us braces with shoulder pads instead of the neck piece for kyphosis, or when that hunchback is starting to form, to try and prevent that. Using a Milwaukee style brace with shoulder pads can be useful. But the Rigo Chanot style TLSO that you see in the top left there, that's a better idea of a form-fitting brace that's really well covered with even just a t-shirt. Sometimes my patients come in, I don't even know they're wearing it, and I'm like, where's your brace? And they lift up their shirt and they have it on. So that's a good option. There's nighttime bending braces. There's been many different studies on different braces, and you can probably find a study to support anything. But what the SRS, or the Scoliosis Research Society, is suggesting most of the time is 23 hours a day. That's pretty much all day. Take it off for a shower. You want a goal of 16 minimum, and they say if you're going to do less than 13, it's probably not doing anything. I spend a lot of time with these patients counseling them. This is not easy. If you told me to wear a brace for 16 hours a day, I'd say, give me the scoliosis probably. But for a kid that's growing, this is their last chance to impact this and keep them away from the next level. So it's so important. And I'm always so shocked by my patients how well they actually do. There's always tears in the beginning. There's always no chance I can possibly wear that to school. And they almost all surprise me. There's always a couple here or there that they can't do it. And I don't blame them. I try to work with them also. But it's really incredible how some of these kids can wear this for 23 hours a day for sometimes a year or two and prevent themselves from getting surgery. It's about 65% effective in reducing the risk of heading towards surgery. That's a huge number. So I mentioned Schroth therapy earlier, and this is key. We have a few Schroth therapists in the area, and it's growing. We've gotten a few at our practice now, and we've went out and gotten them trained because it helps. And the science isn't 100% there yet. It's still a little bit early in terms of the evidence-based medicine, but what the evidence does tell us is it's safe. It's definitely not hurting these patients. If any of us did these exercises, it would probably benefit us as human beings for back pain, for as athletes, whatever it might be. You're basically working on different muscles and trying to adjust the ones that attach to certain parts of the spine by decreasing the tight muscles and loosening the other ones. So a lot of this is posture-based. It is home training as well, and we got a great lecture a couple of years ago on this stuff. So this is something that I've really incorporated into my practice, where I have to be honest, I wasn't always a believer in it before, until I started seeing with my own eyes some real benefit in terms of even decreasing some of our curves. So if you get a decrease in a curve and it even bounces back to where it came from, that's a huge win. And we do see more times than I would ever have thought that curves are improving with this. The other thing is, if a patient is in embrace and they're in embrace 23 hours a day and they're really good about it, I want them doing something active and activating those muscles in their back when they're not wearing the brace. So if they're going to take a few hours a day to play sports, that's awesome. If they're going to do that and also maybe do some of these physical therapy exercises specific that could help their spine straighten out a little bit or help prevent the progression, that's a great use of that potential 8-hour window that they have. The classification for these more severe scoliosis is basically now, the King classification was an older classification, but Lanky classification is really taken over, and it really helps us with perioperative planning. So this is a patient that we know is already a surgical candidate. They're close enough or done growing that a fusion surgery maybe won't affect them. And we're trying to decide what levels are we fusing at this point? How are we going to do this? When are we going to do this? So we don't have to go through all of the details of this, but essentially we started to mention earlier that there are different types of curves. There are single curves, there are double curves, there are triple curves. There are curves that have all three components, but only one of them is structural and two of them are compensatory, and everything in between there. We typically don't have to fuse non-structural curves that are compensatory. We want to fuse as few levels as possible in someone's spine to preserve motion, but still allow them to have the maximal benefit of not progressing their curve down the line. So it's invasive. This is scoliosis surgery. It's a midline cut down the spine. The muscles are peeled off of the bone. You're staring at the spinous processes there. That is possibly my hands, or maybe Dr. Haynes or Colin, someone's hands there on either side, because we do this typically with two surgeons, putting screws into the spine, into the bone, into the appropriate channel to allow for fixation and ultimately correction of the spine. This is what it looks like when it's done, but getting there is involves everything we just talked about. The planning for this patient, you can see they have a curve in the thoracic spine as well as the lumbar spine. Preoperative planning and using the Lanky classification and some data on which curves need to be fused told us that that bottom curve is probably flexible, and without putting a screw in that bottom spine, I'm probably going to be able to correct it to a good amount or a satisfactory amount. You can see on the postoperative x-ray, it's not 100% straight in the bottom of the spine, but it's pretty minimal. Nothing you would ever even be concerned about if that's what they came in with to begin with. The top part of the spine is very straight. This patient's spine doesn't have just screws and rods in it. It has bone graft in it, and it has the bone prepped to be able to fuse around that, almost like rebar and cement. Our goal is to make this not progress. If that bony fusion doesn't ever happen, those rods and screws will eventually break. But when they are there together, it's a very strong construct that will not progress. This has really low complication rates in terms of spine surgery. You see infection rates somewhere around 1 to 1.5% typically. Pulmonary complications are hovering around 1%, but pretty low overall complication rates, and some of the more minor ones added together with this. We consider the surgery about 95% safe, 95% successful. And I'd say it's even probably closer to 99%. Here's another example of a different type of curve. This is double thoracic, so two curves that were both structural in the top of the spine, and very large curves at that. And you can see we spared a few segments in the bottom of the spine there to allow this patient to still be able to bend forward and not reduce their motion too much. Another example, again, in this patient, we tried to stop a little bit short, and we left them a little bit of a residual curve in the lumbar spine to save motion segments. But that's a very small curve in the bottom that, again, we wouldn't be concerned about if that's what they came in with. It's not going to cause them any long-term problems, and it saved them a lot of motion. This patient has a very large lumbar curve. That's harder to stop short, but essentially we fused down to L4, which leaves L4-5 and 5-1 as motion segments for flexion and extension. This patient surprises me every time they come to see me because, one, they almost never had any pain, and I don't believe them, but she wanted to walk out of the hospital day one. And she also can bend forward and touch her toes easily. I can't do that, and I have no screws in my spine. So that's really impressive to me, and it just shows you how resilient kids are and how, even with that, there's really no restrictions after we do the surgery. You can get back to any sport. You can get back to karate. This is a karate kid. Dance, football. I have no restrictions once the fusion has happened. So fusion sounds terrible. It's usually a last resort in orthopedics, but it's the gold standard for a reason because it works really well and our patients do well with it. But there are some non-fusion options, and those are kind of common questions. Are there non-fusion options that will work for my child? And in very specific cases, you can try these things. And one of the things that's been kind of catching fire in the last probably 10 years or so is vertebral body tethering. And what they do there is they put some screws into the front part of the spine in the vertebral body, not the back part where we were showing you before, by usually using a camera in the thorax, so dropping a lung for the procedure, putting a camera in and putting screws across the vertebral bodies. And then between those screws, what you can't see, is a polyethylene cord. You can see it in the diagram below. That is tensioned to correct the spine. This is a flexible construct, which means that as this patient grows, and if they have a flexible enough curve, they can potentially correct their scoliosis without fusing it. The tether breaks a lot. You get overcorrection sometimes, meaning the curve goes the other way. And you're going through the lungs to do it, so you have a little bit more pulmonary issues. But one of the big things when I was doing literature search for this is only 7% in one of these studies of these patients went on to fusion, which tells me it worked pretty well. Even if that tether breaks, maybe it is an option for the right patient. The problem is they have to meet a lot of criteria to be a candidate for it. They have to have the right flexibility, and most patients don't have that. They have to have the right curve type and the right flexibility. But when there is that patient, I would send this to a patient that does tethering if they wanted to. This is a patient-specific decision. Do you want the chance of having to have another surgery down the line? That might be the case with this, but you might do really well. Or do you want the gold standard, probably one and done? You're probably going to have a really good outcome anyway and not notice the difference with a posterior spinal fusion. It really comes down to what someone's goals are, and I'm a big believer in don't tell people what to do, but tell them what their risks and benefits are and their options are and come to a decision together. Another non-fusion option I wanted to mention is relatively newer as well. This is a posterior dynamic distraction. So in order to put this in, it's only implanted on one side of the spine, so it's not quite as invasive as that first picture I showed you of this posterior spinal fusion surgery. And this is a self-ratcheting, elongating device, so over time this can grow as well. It has very specific indications as well, so not everyone's curve is flexible enough or the right curve pattern for this, but in the right patients, this could be a really good option as well, something that I'm excited to see further research on. They had a very high revision rate, but when you exclude the fact that people just outgrew it and had to have a new one implanted that was a little longer, the rate's about 19 or 20%, which is kind of more similar to the vertebral body tethering. Still not close to our complication rate for posterior spinal fusion, but these are emerging technologies that I'm excited for, and I hope that we continue to develop. So thank you very much for that. Thanks for sticking around until the very end of this. It's been a pleasure listening to everyone today and learning a lot from you guys, and thanks for listening to my talk. Any questions?
Great talk. Very excited to hear what EOS will give you. Like, what additional information can you obtain with EOS imaging?
Yeah, I'm excited about the EOS because number one, the most exciting thing is that it gives high quality, low dose radiation. So my patients who are getting x-rays every 4 months, starting from sometimes juvenile cases or even our 10, 11-year-olds, every 4 months, that cumulative radiation dose, there's not really a good study that says it's going to be good or bad for somebody, but in our minds, we know if we could limit radiation for a child that's growing, it's probably a good idea. And that radiation dose, when I know I have to get those x-rays to be able to accurately measure their spine and treat them appropriately to see if they're meeting criteria, that radiation dose is really important to me. And it's important to a lot of my families that, that I'm treating, because they sometimes will even travel out to go get that X-ray with a lower radiation dose. There is good information as well because of the higher quality imaging. It really accounts for body habitus. So some of the bigger patients that you don't get as good of quality imaging on sometimes, it can make those adjustments based on its technology and how it senses as it takes the image. So we get better quality. We can see potentially small areas of more congenital scoliosis with a small fusion. And there are some AI advantage to this coming out in the future, from what I understand, in terms of surgical planning and potentially even pre-contoured rods associated with what curve correction you might be trying to obtain in your surgery. So all that stuff is really cool and on the forefront of scoliosis surgery.
I had a quick question. Great lecture, by the way. How do you feel about the prognosis, or what would you say the prognosis is for a patient with hemivertebrae?
I think the hemivertebrae by itself has a high risk of progression, but not quite as high as if it has a contralateral bar. That's kind of the bad combination. And that contralateral bar means you might have a wedged vertebrae, and on the other side, it's partially fused. So now you have a tether on one side and a growth on the other side that really work against each other. So that patient is the highest risk of progression. But somebody with just one single hemivertebrae, that could be monitored for a while, and sometimes they do really well. I have patients with hemivertebrae that have, shockingly not progressed too much. And sometimes even when you go in for the surgery for that, you can almost treat one hemivertebrae like an idiopathic case. For more severe cases, you have to actually go in and remove that hemivertebrae. It's a much bigger, more significant procedure, more risk involved. But sometimes you can just span that and avoid a much more invasive surgery for an already very invasive surgery.
Thank you.
Thank you.
Hello, thank you so much. We are a group of school nurses that do a lot of scoliosis screening. And I wanted to ask you, on the scoliometer, what is the number to refer? After what degree?
That's a very good question. So we know that 7 degrees typically, and these are not rules, but averages, 7 degrees typically equals a 20-degree curve. At 20 degrees, they're just on the verge of that moderate curve, right? So we're maybe even a little too late. We could have maybe started some intervention before that. I think any rotation, any concern, just send them to be seen, right? If you have any, I'd rather see a few kids that don't have scoliosis that you thought maybe did because they had some asymmetry in their scapulas only or something. If there's any sign of it, it warrants an investigation, especially in that age group where we have to make these decisions now or we're going to miss it. But you guys, I didn't realize we had multiple school nurses. Thank you guys for being here, and thank you. You guys really catch so many of these that would otherwise be missed, I think. And the pediatricians together with all of you guys, there was some talks at one point of, do we need a school screening program for scoliosis? And that blew my mind. Why would you not do that? It's not invasive. I mean, I guess kids getting in line and taking off their shirts is one thing, but it's pretty private. I'm sure you guys do a good job with screening. You keep it private, and it just doesn't make sense to me to ever remove that from our guidelines. So,
my next question is, what is your name, and where are you located, and how would we refer to you?
My name is John Lentz, and I work at CV Orthopedics, and we do most of our scoliosis stuff right here at Jersey Shore. Dr. Haynes, Dr. Collins are also my partners. Dr. Amit Merchant is another pediatric orthopedic surgeon there, does the same stuff we did, and probably does the exact same thing as me because we trained at both the same residency and fellowship. So kind of all of us together, we can give contact information for referrals, and happy to see anybody anytime for you. Send them our way.
And EOS machine coming summer 2024.
Late spring 2025.
Thank you, 2025.
Yeah, we're very excited about EOS. We've been building a building, special plans for it. It's coming in, and it's gonna help us out a lot and help our patients. Dr. Haynes, any questions?
None. You covered everything so well, sir. Very nice job, seriously. It's great. I really want
Thank you again to everybody.
In particular, Dr. Lentz for hanging in for so long, and Dr. Collins for his commentary and introductions. And again, we want to thank the entire team. There will be some additional information online afterwards. Any questions, you reach out to our team. Thank you all very much.